to today's meeting. Just remind you again of the sensitivity of your microphones. Today we have 3 briefings, so just to keep that in mind in terms of the timings. So the first briefing we have is with the departmental officials on the Adult Protection Bill. Then we have the Royal College of Midwives on maternity services, and then we'll have a briefing from the department on maternity services following that. So just to declare the meeting open to the public, and to remind members the meeting will be recorded and broadcast through Parliament buildings and online. And just if you can keep your mobile phones muted or on airplane mode. I'm not aware of any apologies, but I know that Diane Dawes and Nuala McAllister will both be joining remotely, and Diane will be a wee bit late in, so we'll keep an eye out for them. I have no chairperson's business this week. If we could refer members then to the draft minutes of the meeting last week on the 9th of May at page 6 of your meeting pack. Are members content with the minutes? Yeah. I have no matters arising. If anyone else has anything they want to raise there. No. Okay, members, I'll give a wee second and we'll go into our first evidence session, which is with officials from Department of Health on the Adult Protection Bill. And it's on page 16 of your pack. You're very welcome. In attendance today we have Mark McGuckin, who's Director of Disability and Older People for the Department of Health, and Carrie Loveland Morrison, Head of the Adult Safeguarding Unit in the Department as well. So you're both very welcome. Thank you for your time today. Members, we have about 40 minutes for this session, and as I said, we have 2 briefings afterwards, so I really appreciate if people can stick to that and keep your questions brief. Okay. The session will be covered by Hansard, and I'll now open up to officials. So thank you.
Thank you, Chair, and thank you for the opportunity to provide the committee with an update on the Adult Protection Bill. As you've mentioned, I'm joined by Carrie Loveland Morrison today, who's the head of the Adult Safeguarding team within the department, who've been leading on the drafting of the Adult Protection Bill. I'll do my best to keep my opening comments brief, Chair, and allow plenty of time for questions. You've seen from the briefing paper in September 2020, the Minister Swan announced his intention to consult on legislative options to inform an Adult Protection Bill, and this was largely following the failures at the Murray Manor Care Home and Muckmore Abbey Hospital. Subsequently, the consultation ran from December 2020 to April 21, which then led to the policy proposals being brought to the Executive in October 2021. The Executive gave their approval for the Department to commence drafting the legislation thereafter. The current position is that the draft bill is close to completion, and the paper submitted provides details on what is included in the draft bill. However, to provide a bit of background, the draft bill will essentially introduce additional powers and duties to strengthen and improve the adult protection process and bring Northern Ireland in line with other parts of the UK where such legislation already exists. The Republic of Ireland does not currently have specific legislation in relation to adult safeguarding, but Kerry and the team are in regular contact with the other 4 jurisdictions on a range of safeguarding issues. You'll see the draft bill is largely based on 7 key principles. They are prevention, autonomy, empowerment, dignity, proportionality, partnership and accountability. And these have been incorporated within the draft bill and should be adhered to by everyone involved in adult safeguarding and adult protection going forward. The draft bill will place a duty to report and a duty to cooperate, where a number of organisations such as Health and Social Care Trust, PSNI, RQIA, Probation Board, Housing Executive, GPs and independent providers of health and social care will have the duty to report to relevant health and social care trusts any cases where they believe an adult is a reasonable cause to suspect an adult meets the criteria of an adult at risk. Subsequently, the relevant health and social care trusts will have a statutory duty to make inquiries into all cases that are brought to their attention. The draft bill will also introduce the power to access records, and this will include financial records, the power of entry and associated additional powers such as an assessment order, removal order and banning order. These powers will be used by specifically trained adult protection social workers. A number of conditions that will have to be met before any of these powers can be used. For example, magistrate's approval will be required in all instances, and there must be a reasonable attempt to seek the consent of the adult involved if they have capacity. The draft bill will also introduce a statutory provision of independent advocates who can assist adults at risk to be involved in and influence decisions taken about their care. The draft bill will also empower the Department of Health to establish an adult protection board for Northern Ireland and place it on a statutory footing. The board will have a number of core functions, which will include having responsibility for carrying out and managing serious case reviews. And finally, the draft bill will also see the introduction of new offences relating to ill treatment and willful neglect. There's two specific offences in the bill, namely the care worker offence and the care provider offence, which are intended to cover instances of harm by care workers and care providers which are not currently captured within existing legislation available or offences available in Northern Ireland. These offences are similar to those already in place in England and Wales under the 2014 Care Act. As I already mentioned, the bill is a draft. The draft is very close to completion with one minor outstanding issue. It's worth noting that this issue would not prevent the bill as drafted progressing, and because this could be addressed through amendments throughout the passage of the bill if necessary. At present, Kerry and Bill team colleagues are working closely with Departmental finance colleagues to finalise and agree the business case, which will then need to be approved before the draft bill can be introduced to the Assembly. You will see from the paper that the current estimates have indicated the implementation of the bill will cost approximately £16 million per year, or in year one, and £160 million over the 10-year period of the business case. With the number of current pressures within the department, it's worth noting that this will have to be new funding and is not within existing baselines. The additional costs are largely attributed to additional staffing costs associated with implementing the new powers. Therefore, it's unlikely that all staff will be recruited in year one, and is expected that the actual spending staffing will be less than anticipated in the business case, and there'll be a more gradual increase and incremental recruitment that takes place over a number of years. The bill has been highlighted for inclusion in the Executive's legislative programme as a year one priority. And subject to the progression of the necessary financial approvals, this bill could be brought to the Executive immediately. And Chair, I will be happy to take any questions. If we can't answer them today, we'll obviously write back to the committee. That's okay.
Thank you, Mark, for that introduction and for the briefing paper ahead of today's meeting. I have a couple of questions and opening up to others. So, I mean, this is a very important piece of legislation, and as you've referenced some of the cases that we'll all have been aware of, and the implications of that and the impact on the people involved. So it is very, very important that we are able to bring this forward. I suppose one of the things and particularly coming out of what we do know has happened in the past, partnership working is so important going forward. So it's just to try and get a wee bit more detail around that, how this bill will envision that in terms of all the relevant stakeholders, which is service users, families, carers, care workers and providers, the trusts, RQIA and the PSNI, because sometimes I think that's when it's disjointed, that's when maybe things can go wrong. So if you maybe talk a wee bit more around that, what you think that would look like.
The bill has been developed under the auspices of a project board, a programme board within the department. And the department is represented in that at both official level and through Office of Social Services and SPPG, RQIA, DOJ, PSNI trusts and the ambulance service all sit on that board as well. We have regular engagement through PCC with families who have been affected through Dunmurry Manor and Muckamore as well. So the duty to report within the bill will actually make it a statutory responsibility for those named organisations to report any instances where they believe an adult may be at risk. So that partnership approach has been built into this, Chair. It's been built in through the development of the bill and placing those powers, or those statutory powers, on a number of named organisations. I mentioned we've one issue outstanding, and that's in relation to we've ongoing discussions at the minute with Prison Service around whether they should be named on the face of the bill as well, in terms of a partner who should have a statutory duty to report. So. There's also a clause within the bill, and I'll maybe turn to Kerry to give a bit more detail on this, in terms of keeping families informed as part of that process as well, where that is possible. Where if it's thought that the family is the cause of the potential harm to the adult, obviously it wouldn't be appropriate to keep the family involved in those circumstances. But another part of the clause of the bill is around that, making sure that families are kept involved throughout the process of any investigation.
Okay. No, thank you for that. I suppose then you'd mentioned as well around those new kind of offences of willful neglect, and you referenced care workers and care providers. I mean, and I've worked in safeguarding, so just I suppose to declare an interest in that. But obviously there's other people who can be responsible for abuse of older people, for example, and it can be family members, it can be neighbours, it can be friends. So is that incorporated into those offences as well, around willful neglect or in terms of carers?
Yes, I think it was thought that there was a particular gap in the law around care providers and care workers. Those offences are similar to offences that are in the Care Act in England and Wales at the moment, and we didn't have similar offences here, so that was why we particularly focused on those. But we've all worked with PSNI and regulators on this, and it was thought that that was a particular gap, so that's really why.
Okay, no problem, thank you. And I suppose then, my last question, and I'll move on to others. You mentioned the cost, and obviously we're in a very difficult financial situation, and we're hearing that week on week. But I suppose, has there been any consideration given to if this is properly implemented, and in comparison with if we don't? And the risks. So given the example of the likes of Dunmurry Manor and the huge amount of money that would have cost then in a retrospective way of doing an inquiry, and all of the work that's involved in that, which it takes a lot of time. Is there any sort of comparison given? And maybe you can't answer that today, but that in the longer term this will probably be cost saving because people are getting the care that they need, and there's properly governed and all of that accountability mechanism, rather than having to deal with where issues arise and people have been victims of abuse and everything that's involved with that.
We haven't, Chair. One of the parts you have to do as a part of the business case process is basically a do nothing option. So the do nothing option basically will look at if abuse was to happen again and we didn't have these regulations in place, we couldn't investigate them properly, we couldn't prosecute properly. We haven't actually done the analysis to say, but how much would that cost? We basically based the business case on how much it would cost to implement as opposed to how much it would cost not to implement, Chair. But I'm not sure we have any figures on that at all, Chair.
No, we wouldn't do today, but I do think that that's an interesting point. I also think, we've been in contact with the trusts throughout this, and the message from them is very clear that more resourcing needs to be put into safeguarding. And so that's where all of this has come from.
Yeah, and I suppose just my last point, maybe not so much a question, but I mean, we've had some of the different stakeholders in from the health and social care system. So we had RCN a few weeks ago, and one of the things we've talked about, and I've been dealing with individual cases of where this maybe has happened, but because of the huge pressure on staff, health and social care workers, things can happen, and not intentionally, but in many cases that will go down an adult safeguarding route. So I think the thing around that is as well that has to be factored in at things, and how that's dealt with then, to make sure that we're reducing the risks of things like that. And that's not just something that's covered by this bill, but that feeds into that whole health and social care governance and safe staffing and the links with maybe the safe staffing legislation as well.
And part of the costs associated with implementing the bill, Chair, are in terms of a wide-ranging education programme and training programme across all the health and social care providers. So it's not just those individuals who will be involved specifically, but it's around making sure that safeguarding and protection is on everybody's agenda, so they know what is appropriate and what's not appropriate. So it is, as part of this, there'll be a wider training programme across all areas.
Okay, thank you. I have Nuala first.
Hello, sorry. Apologies, I'm not there in person. And thank you for that presentation, Mark and Carrie. I have a number of questions that I want to ask, and I had been in touch before through written correspondence regarding the inclusion of mandatory CCTV within the legislation. But before I go on to that, I just want to say yesterday in the Muckamore inquiry, they did hear from the social worker, Geraldine O'Hagan, and the families obviously have been working with Geraldine, and will note that they did give her an ovation after her evidence was read in, and I just wanted to put that on record, that we as a committee are also grateful to the social workers who did bring light to a lot of the instances that took place in these adult care homes. But this legislation is welcome and much needed. And I just wanted to ask a question regarding those safeguarding elements for the staff, so that people like Geraldine don't ever feel again that they can't come forward because of fear of losing their job or else anything else, or feel that even when they do come forward, that perhaps everything isn't followed through. So I just wanted to ask around those kind of whistleblowing elements contained within the review panel or team that will review board that will be set up. If you can just shed any light onto that, please.
I suppose the Adult Protection Board, Nuala, I'm not sure that we have specifically looked at whistleblowing as part of that. Whistleblowing arrangements are already well embedded within the trust, and there's a process there for taking those processes forward in those sort of circumstances. The Adult Protection Board will largely be responsible for taking forward the what was the terminology? Sorry, no, they should do the serious case reviews. So that will be largely their role. I suppose because we now have a statutory duty for any incidents that are reported to be taken forward as part of the bill, I suppose it will clear up any of those whistleblowing issues that aren't taken through the normal whistleblowing process within trusts, because the trusts, for any incidents that are brought through where they believe an adult is at risk or at risk of harm, then they have to be taken through the process by the trust it's reported to.
Thank you. And I recognise that there will be that statutory duty, but there's a statutory duty on a lot of other issues when it comes to the trusts and when it comes to the department, and not just health, but a lot of them that do exist already. So I just wanted to ask if any additional work, I'm not asking for an answer right now, can take place around the whistleblowing policies, just to make sure that, you know, everything is as strengthened as it could be. And as I said, I don't expect an answer today, but I just wanted to move on then to the CCTV. I understand that mandatory CCTV wasn't part of the public consultation. I was actually really disappointed that it wasn't part of the public consultation. When we speak to families, whether they're involved in Dunmurry Manor or they're involved in Muckamore, you know, the fact that there was CCTV for the police then to actually see is going to be, and it is helpful now, but is going to be helpful in the future. And even the police have spoken out about the use of CCTV and the fact that it has helped them in their role. I just don't understand this process of an enabling power to bring forward regulations governing the use of CCTV in social care settings. What does that actually mean? What does that mean, you know, for families who, whenever they want to put their loved one in a home that is going to put their mind at ease? And I've asked them, would you prefer CCTV without it? Yes, no. And obviously there are issues regarding privacy, but what does that actually mean in terms of addressing the concerns that families have, and that I would have for any future loved one of mine regarding the use of CCTV? Enabling powers to bring forward regulations. If I don't understand it as an elected representative, I just want to see how we're going to get the public to understand it, but also realise that can be a powerful tool.
Essentially what that power means is that it will allow the department to bring forward regulations which would govern how CCTV is used when it is used, and part of that would be a requirement for institutions to consider whether it is appropriate to use CCTV. You've raised a lot of points there, Nuala, that we have heard from families when we have talked to them, and we've heard that message from the PSNI as well, the importance of CCTV, how helpful it has been in terms of uncovering abuse at the likes of Muckamore, and we have certainly heard those messages, and we have discussed them with our transformation board in the department at great length. We have also talked to the Office of Legislative Counsel and to departmental solicitors to receive legal advice on this, and essentially we have been advised quite strongly that we're not able to bring forward something that would make CCTV mandatory. it would be difficult to make something mandatory when there's nothing that stops CCTV from being used at the moment. Additionally, DSO did feel that it would potentially render the bill outside the legislative competence of the Assembly if we had something like that in it. So the legal advice we received was very strongly that we could not do that, and we believe that the enabling power to bring forward regulations that we are recommending is the strongest thing that we would be able to do in relation to CCTV at present.
It was an issue now that was discussed at length in the Transformation Board, and there were very, very strong views, as you've said, from PSNI and others and families, but we did discuss it at length with the Office of Legislative Counsel as well when drafting the bill, and as Kerry said, with DSO, and that is the advice we've been given, and it's very difficult for us as officials to go against that legal advice in terms of the drafting.
And I respect that it would be difficult for you, but whenever we haven't seen that legal advice as to why it can't be made mandatory, it still doesn't address all of the concerns. I understand that being outside the legislative competence. Is that the only reason, or were there other reasons? It's hard to agree with it if you don't see the entirety of the legal advice.
There were also a number of issues on European Convention of Human Rights grounds, so concerns around privacy as well. But again, as I said, there was concern that we couldn't mandate something when there's nothing to stop it from being done now. So CCTV can be used now. There's nothing to prevent that.
Can you mandate that they at least consider it, that they at least actually assess the appropriate? Can you mandate that they assess whether it is appropriate or not?
That's one of the things that we would think should be included in the regulations, that it should be considered. Also, I should add as well, because I know some of our stakeholders would have concerns that this wasn't part of our consultation. It would be the intention to have a full public consultation on the content of those regulations when they were brought forward.
And do you see that something in the future mandate or within this mandate?
I suppose that would depend on how quickly this draft bill could come through.
Okay, thank you, Chair.
Linda?
Thank you, Chair. Number of just quick points first, just on the back of what others have said. I know you had said in relation to Liz's question around people who might be abused within the home or within their own home by family or by friends or neighbours. Is the gap because that falls under the domestic abuse legislation, that would be captured within the domestic abuse legislation?
I think that the Transformation Board were content that there was enough already on the statute book that would cover some of those. I'm not sure, Linda, whether it's directly under the domestic abuse legislation. The PSNI were content there was enough other legislative vehicles to take prosecutions or forward in those circumstances. It was specifically around care worker and care deliverer that there was a specific gap.
Well, that's fair. I know the intention of the domestic abuse legislation was to capture all kinds of abuse within the home, so that's why I was asking that, just in the hope that that would be the answer. So the bill it is now entitled the Adult Protection Bill, but it was previously advocated that it would be the Adult Safeguarding Bill. Is there a reason why that was changed? And I think maybe just my nervousness is around the intent, because obviously we want to ensure that we're proactive rather than reactive, and that goes back to some of the stuff that's already been said. So I'll let you answer that before we go on to the next one.
Yeah, that's absolutely true. I think the feeling was that safeguarding is very much an umbrella term that covers many different aspects, including prevention, including protection. And it was felt that in terms of legislating, what we're doing is trying to stop abuse as it happens, trying to put the right measures in place to bring prosecutions forward where necessary, allow people to take action where necessary, and that those measures are protective more than anything else. And so calling it the Adult Protection Bill more correctly indicates what this bill will do. However, that's not to say that the other aspects of safeguarding aren't still important. They certainly are.
Okay, I appreciate that. Thank you. Just again, in terms of follow-up to what others have said, I mean, I think that Nuala's point is a fair enough one, but I understand the challenges that you're up against, and maybe we as a committee could ask for our own advice around that. I mean, I don't think that the department can share their legal advice with us. As far as I'm aware, legal advice belongs to the department. It can't be shared with the committee. But
we can request.
But we could, yeah. I just think maybe just to get an understanding of it, but I get where the complications might be around that. And then just, I suppose, the last question around the current criticism around safeguarding processes, you know, lack of evidence of improving outcomes for service users, for the staff, for care providers, health authorities or regulators. So how does the proposed bill address with that criticism?
I suppose for us, putting that statutory duty on a number of organisations who it probably doesn't fall on the minute, Linda, would bring in certain protections. Obviously, through serious case reviews, there'll be lessons learned, and we will need then to make sure that any lessons learned from that are disseminated throughout the system, and ongoing training will be updated as we learn. We're learning lessons from Dunmurry Manor, we're learning lessons from Muckamore Abbey Hospital, so that sort of thing has been built in. Some of those, the lessons already learned have been built in to what we're proposing in terms of the bill. So I suppose as the Protection Board starts to look at some of those serious case reviews and the outworkings of that, and any prosecutions that come through, we need to ensure that any gaps that appear through those prosecutions are then filled through amendments to the bill or through other guidance which is issued.
And I would probably like to bottom out at some point what is meant by harm, and if we're able to be flexible around that, because obviously harm can be ever evolving, the types of harm that can be. I'm not sure maybe if you're in a position to do that now, or whether that's something we need to do when we get more into the legislation. And I suppose just as a final point, as somebody who has worked with families who had family members, loved ones in Muckamore who suffered, just to say that, you know, the cost is one element of it, but the cost to those people's lives is irreparable. I mean, some of those people who were in Muckamore have been irreversibly damaged by what happened to them, and there's nothing we can do to help them now, but we need to make sure that we never allow it to happen again to any other person and their family, because that has a knock-on effect, as you know, to the entire family. So I think it's just worth pointing that out, just on the harm. But if you aren't in a position now, I'm happy to hold off until we get sort of more into scrutinising the bill. But
it's probably easier to do that as we go through the bill. But on your second point, Linda, in terms of the families who've been affected through Muckamore, obviously one of my areas of responsibility is the Muckamore Hospital and the resettlement, so we meet quite regularly. But there have been amendments we've brought as part of this drafting of the bill, which have been direct requests from those families. So some of the issues through our engagement platform, through PCC, issues have been raised. We have brought them back to the Transformation Board, and the bill has been changed, draft bill has been changed as a direct response to some of those requests from the families. So we are listening, and we are trying to make sure, but I agree, the damages are irreparable, and no matter what we do, those families will. I think there's an awful lot of trust to be built back up with the system, and that's where we've tried to continually engage with those families who have been affected through the PCC. It's very challenging at times because we can't share the draft bill with them, and the same way we can't share the draft bill, and we're trying to say we're listening and trust us, and that's very, very difficult for them. But we have taken on board the commentary from the engagement through PCC, and the bill has been changed as a result of that.
On that, I apologise, Chair, but just quickly on that basis, so when will it be shared with them? So for example, around HIA and mother and baby, it's shared with the victims and survivors. Almost, actually, it probably will be before it's shared with elected representatives. I think that's fair.
The HIA inquiry legislation was shared with them before it came to the Assembly, although that was a special circumstance that they had to get permission for. The normal procedure would be that no one sees the bill before it's introduced to the Assembly.
Alan?
Thank you, Chair, and thank you very much for your presentation. I think we're probably going to start seeing a lot of each other over the next 6 months to do with this. So one of the things I was interested in maybe looking at is the impact on the sector. I'm sort of hearing figures of around about 60 social workers, I think even per trust, maybe to implement if we do establish this. And obviously the social work fraternity is quite small and it's under a lot of pressures, and if we want to see, as this committee has asked for, a rollout of MDTs, which will then move social workers out of the social work profession and into you know, across various health centres and the training places that are available for social workers within university. I think there was a slight increase, or there's a suggestion of maybe 40 places, but if it's going to be 60 per trust, that's 300 that we might need. Now, granted, this is going to be sort of maybe 5 to 10 years down the line. So is there a plan alongside this to try and up the number of social workers that we can have to be able to manage with the implementation of this?
The bill, or the costings for the bill envisage around 120 new social workers at band 7 and 8, I think they are. Now, there will be other staff involved as well at bands 5, yet 67s and 66s. There'll be additional staff then at band 5, band 4 and various other grades. Now, the current, my understanding, the current intake of social work students is around 300 per year. Around 285 of those are trust sort of places, and another around 15, I think, are youth justice agency, probation and others. This year there's been an additional 40, as you just mentioned, Colin, in terms of MDTs largely. We talking to OSS colleagues, Office of Social Services colleagues, they reckon that they would need around an additional 60 training places over around a 5-year period to ensure there's enough staff in the system to be able to accommodate what we need for MDTs and for this bill. So we would never envisage these being newly qualified social workers. They'll be a band 7, band 8 social workers, so they'll have that experience and before they come out. But it is about making sure there's enough in the system to allow people to fill these roles in a more senior role and continue to bring enough staff in at the bottom. That is something we continue to struggle with in terms of funding of those places, but it is something that the Office of Social Services are developing a social work strategy, and part of that strategy will be around the training places and how we take that forward. But I say it's around an additional 60 over a 5-year period would get enough additionality into the system to allow us to fill these and the MDT roles as well.
I think it's really useful information, thank you for that, and I think it's something that maybe from our scrutiny role we really need to keep a close eye on, just because I think this is sort of binocular viewing. We can see that 4 or 5 years down the line there's going to be, especially if the band 7, band 8 jobs, that's going to be very attractive to those that are in lower grades in social work, but then if they all hemorrhage up into there, then the lower grades are going to be left struggling to be filled, and we know that there's a crisis within particularly family and childcare, which is often left to the lower grades to go into, and they typically last a period of time and then move on to different jobs. So I think any pressure that we can bring as part of the passage of this bill to make sure that there is the provision and the proper number of places, because then that's what we all want. We want the best world for everybody, which is the right number of social workers to be able to do the job. But that information's been useful there.
And that concern has been raised by trust colleagues on the transformation board around the impact it will have. So that's why we've made sure that the costings in the bill cover as much as we can in terms of building that sustainability into the system.
Thanks. Thank you, Jim.
Danny?
Thank you. You might have just answered one of my questions now. Certainly this is an awful issue, and I can't begin, as Linda said, the effect that it's had on victims and their families is horrendous, and you can't put a price on safety. Protection from abuse is absolutely paramount. So the cost is what the cost is. I was just a bit concerned about the difference in the estimates. The initial estimates, 807,000 and then 821 annual costs. That has gone up by a factor of 20 by the look of things in 5 years. I take it, is that in relation to the extra staff that you're going to have to bring in? I know you mentioned the education piece there as well, and you'd mentioned the expansion of the social work programme. Is there any other reasons for that level of increase?
I think it's really just a reflection of the amount of work that we have done since those initial estimates were made. Those were based on very early estimates between ourselves and the trusts at the very start of our work, drafting the bill before we had worked out exactly how much would be required of everyone involved. We have since worked extensively with all 5 trusts and also with the Office of Social Services to bottom out what this really means, to try and work out a fair estimate of the increased workload that this is going to mean for all bodies involved. And so that's really why the initial estimates weren't close to what we're seeing now.
And just so you're aware as well, Danny, we have based this on, we've looked at Scotland, and we've looked at how many cases have gone through the courts in Scotland. Then we've extrapolated that down in terms of the population size of Northern Ireland. So this isn't the finger in the air job at this stage. It really is as detailed as we can make it based on the experience in other jurisdictions and how that might impact here, how many cases would go through, how many banning orders might go through. So the figure work now is probably as detailed as we could make it, and it goes down as far as levels of how many additional desks would we need, how many additional phones. You know, it is very detailed to make sure that when we get this implemented and we get the bill through, that all of those costs are covered, and trusts will be able to run with this very quickly then after that.
Just with your point about the serious case reviews, obviously very, very important when these are necessary. From a systemic point of view, does the serious case review look into the pressures on the system at the time? So we're talking about the workloads, the staff, the pressure on the staff shortages, everything that's happening in that area where a case is being reviewed. Is that part of the consideration in a serious case review?
I'd look into the details of that particular case.
Mm-hmm.
We would envision that they would happen in very serious cases where someone had potentially died or was at risk of that. They're similar to the case management reviews that would happen in the child protection world.
Mm-hmm.
But they also happen in other parts of the UK as well. So we think it will be useful to have that option available to us here.
Systemically, a lot of our staff, and we hear this again and again on this committee, a lot of our staff are working under extreme pressures, you know, right across the system. Is that a factor in these serious case reviews? Is that something that's considered? Is the pressures systemically considered?
I think they would consider everything relating to that case.
Yeah, and it will be whether there's lessons to be learned
Yeah.
from the wider system as well. So if it comes out from a serious case review that it was because of sheer lack of pressure on the system, or a lack of numbers in the system and not being able, or workloads or caseloads or anything like that, it will have to make recommendations. My view would be it would have to make recommendations in terms of how you make sure it doesn't happen again, and if that's more staffing or that's smaller caseloads or it's a different way of working, it will be up to the board to make those recommendations as part of that serious case review, how they could be alleviated going forward now. So it would look at the totality of it. It can't just look and say this incident happened in this specific area. It would have to look at the wider, as you say, the wider systemic issues around how that happened. But again, it would have to also look at the specific instances, as Kerry said, if there was a death or there was the potential of someone. It would have to look at the specific incidences around who was involved, what the circumstances were there as well. So I would imagine they will look at both. Yeah.
Is that whole environment piece that the people are working in at the time, and what's happening on the ground at the time. Just one last thing, Chair, if you don't mind. We talked about CCTV there previously, and I'm just wondering, in the absence of CCTV, how can you be sure that any of this is going to be actually enacted? So if we don't actually have CCTV in a premises, how do you know that anything is?
Well, I would say that trusts have all been very supportive of the work we're doing and very keen to be involved in it. We're not developing any of these policies without them. We're developing it alongside them, and they recognise as well that there are things that need to change, there are things that we need to do better. So I think that it has very much been a partnership between us. So I think that we don't need CCTV to make people realise we need to change. I think we know that we need to change. So.
I think that there is, as Kerry said, there's a responsibility on us as officials to do as much as we can in terms of the legislative change and where we can make this. And it might well be that as you as a committee, as it goes through, you might make changes to this CCTV. We've taken as far as we possibly can in terms of the advice we've given. Mm-hmm. I think there genuinely is a will on the part of the system to change, and as Kerry said, there's certainly been a will in terms of the senior officials from the trusts and the likes of the Chief Social Work Officer and her colleagues on the Transformation Board in terms of driving that change forward. Mm-hmm. I think part of the education programme, which is part of the bill and the cost of the bill, will again drive that forward, and nobody will be able to say in a health and social care setting, I didn't know, or I didn't know it was my responsibility. Mm-hmm. And so that, married with the sort of offences within the bill, I think will make it a lot stronger. I know there, and rightly so, there's a lot of focus on CCTV. I think the other parts of the bill as well will bring a lot more security, for want of a better term, around the whole safeguarding protection arena. So I think there are changes within the bill, even in the absence of mandatory CCTV, which will make some of the most vulnerable in society an awful lot safer than they currently are. Particularly around that whole duty to investigate anything that is brought to a trust. I think that is one of the strongest powers, which will change where we currently are.
And there also is in the bill the establishment of the Adult Protection Board for Northern Ireland, which would have responsibility for looking at the whole piece of adult protection on a regional level. So that role will also be there as well.
Okay, thank you.
Orlia?
Thank you. So see, just on the issue of the independent sector, is there any instances where you might have an independent provider who wouldn't be connected to a trust? And if so, would they fall anywhere within this bill? And I don't know if there is, but I was just thinking it as you were speaking.
We do capture independent providers under the duty to report. So they will have that same duty as all of the statutory providers as well.
But would you? Is it the case that all the independent providers would be connected to a local trust area for that trust area to be able to investigate?
They will be within a trust area, whether there will be some provision which is not trust contracted.
Yep.
I think that's what you're saying. So, but the duty will still be on those independent providers. If something is brought to the trust's attention, the trust will still have the responsibility to investigate that, whether it's trust contracted or not. Yeah.
Okay, and see, just on then in terms of the trusts taking on the investigations, are the trusts sort of content? Are they happy enough that they would have, or they'd be able to build the infrastructure, the resources, the knowledge, the expertise to take on then, that piece of work? In terms of the actual investigations, are so whenever you've been speaking with them up until now, are they content that they're able to take this piece of work on? Because it's big. I'm sure it'll be big, heavy pieces of work in the instances where there is reports of harm.
So a lot of what we're dealing with in terms of the additional staffing are around, it's around band 6 and band 7, it's also around information officers, it's around minute takers and all that sort of stuff. So they're saying this is what they need to be able to deliver what the bill says they have to deliver. So the proof will always be in the eating earlier, and we will need to look at this as it's rolled out, if that is enough or if it's too much. But certainly to date the trusts have been very heavily involved in terms of we've gone out to trusts on numerous occasions now to make sure that the detail and all the information they've provided for us about what it will take to deliver is as robust as we can possibly make it at this stage.
No, that's great. And just finally then, in terms of how senior will the roles be, who oversees these investigations? Is it director level, is it chief executive level? Has that to be worked out and defined in terms of how senior these investigations will take place? And also then in terms of the recommendations, or any learning coming out of the investigations, who oversees the learning and the recommendations? Is it the trusts overseeing their own sort of learning, or you had mentioned there, Kerry, around the Adult Protection Board?
Yeah, the Adult Protection Board will have a role there as well, and they will have an independent chair. The trusts, I think the investigations are done at a band 7 level.
Well, they have said, and we can provide this detail to the committee if that's helpful. In terms of the overall staffing, the governance, the senior governance will be done at 8C level. The operational governance, oversight and monitoring of the investigations will be done at 8A level. Now that would be in addition to, so we're talking about over the potentially an additional 4 band 8As per trust, 1 band 8C per trust and 2 band 8Bs per trust as well, to oversee that overall governance. And as Carrie said, the board then would have the responsibility of implementing sort of regional changes to the safeguarding.
Okay, that's great. Thanks very much.
And just Alan Chambers then. So
just a very quick question in relation to CCTV. Will there be any guidance given as to how long the video recordings have to be archived?
Yes, we would we would detail all of that in the regulations themselves, and as I said before, we would intend to consult on the content of those regulations before they would be brought in. Also, I didn't say this earlier, but we would also intend for those regulations to be brought in with draft affirmative resolution, which is the highest level of scrutiny regulations can be given.
Would there be any guidance given as to CCTV been monitored within the care homes? You know,
Yes.
I mean, it's only as good as people.
Yes, absolutely. The regulations would need to cover how they're monitored and how often, who would be able to look at that footage. It would need to cover all of that detail.
Certainly, the lesson that's come out of Muckamore is the value of the archived video recordings. Yeah,
Absolutely.
thank you.
Okay, thank you both. That's been very, very good, and I think we've probably a lot more questions as we go through the bill, but hopefully it won't be too long till we're dealing with that. So thanks both of you for your time today. Okay, members, our next briefing then, if you refer to your pack at page 22, we have now got a briefing from the Royal College of Midwives on maternity services. Which we have an hour for this maximum, so if we can be conscious of that, please. Linda.
I'm going to get into it. That's why I want to ask Lanty on that, because that's maybe that's what I'm interested in. So I'll let you know later. I was just going to say, maybe are we better waiting until we're actually dealing with the bill to request that? So, yeah, that's okay. No, that's fine. I just thought of that afterwards.
Very quickly about that.
No, that's fine.
Okay. In attendance today, we have Karen Murray, the Director for NI from RCM, and Stuart Bonner, Public Affairs Advisor for RCM. So you're both very welcome, and thank you for your time today. As I was just saying, we have about an hour for the session, so just invite you to make your brief opening remarks. Thank you.
Thank you very much. And the opening remarks will be based on the briefing paper that we presented. And again, thank you very much for having the opportunity to appear before the committee today. I think the first item I'm going to talk about is around the midwifery workforce. For midwives to deliver safe and personalised care for all mothers and babies, maternity services must be adequately staffed so that the normal fluctuation in activity and acuity are accounted for within established staffing numbers and skill mix. The number of midwives working in Northern Ireland has been remarkably stable in recent years at a little over 1,000 whole-time equivalent midwives. We're not yet seeing an expansion in the size of the workforce despite an increasing number of students and therefore new graduates. What is particularly striking is the comparison of the 20.7% growth in the full-time workforce in the HSC alone, which is not reflected in the midwifery growth. What we are seeing, and it is a positive, is a balancing of the age profile of the workforce. The proportion of midwives aged 50 or above is dropping from almost a half in 2016 to around a third in 2022. The number aged up to 35 rose from a small fraction to more than a quarter in the same period. This progress, achieved through the expansion of student midwife numbers, has successfully addressed a crisis the service had been facing of large numbers of midwives retiring over a short number of years. This new, younger age profile is welcome, but it can bring its own challenges. As we bring newly qualified midwives into the workforce, we can find it more difficult to achieve an appropriate skill mix. Additionally, we need to support this new workforce with excellent preceptorship, providing personalised support for them as they settle into their new roles, continuing professional development and clinical leadership. There is a critical need to focus on retaining experienced midwives who can support these early career midwives and who bring such a depth of experience to the service. It also means that more midwives, a profession made up almost exclusively of women, will be out of the workforce for significant periods of time on maternity leave. This, along with other absences, requires that when mapping workforce requirements, we factor in for an appropriate uplift. It is also important to be mindful that midwifery is a largely female workforce. Greater than 60% of midwives are working part-time, and this reflects the reality of working women balancing home, family and caring responsibilities. It is also, in some cases, a choice which reflects the physical and emotionally challenging nature of the work. Recently, Birth Rate Plus, a well-tested and recognised workforce tool, was applied across the 5 health and social care trusts to identify the number of whole-time equivalent midwives required for each unit. Birth Rate Plus assesses case mix, medical complexity and acuity to produce results consistent with safe staffing standards. This review concluded that there was a deficit in total midwifery establishment of 80.93 whole-time equivalents across the region. And just to point out, there is a typo in your written briefing around that number. This deficit in workforce establishment is not evenly distributed across the HSC trusts. And although it seems a small number, as a proportion of the total whole-time equivalent midwifery workforce, it is significant at sitting around 7.5%. This seems to confirm the findings of a SNAP poll of the Northern Ireland midwives and maternity support workers conducted by the RCM in mid-April, which found that midwives in Northern Ireland were working a total of over 4,300 hours unpaid overtime per week. Additionally, 2/3 of the respondents to that SNAP poll said that they did not feel that their unit was safely staffed during that week. It is clear that the HSC does not yet have enough midwives, although progress is being made. In December 2023, the number of midwife vacancies being actively recruited to was 66. It had been 129 the previous December in 2022. This is to be commended and is a reflection of the additional investment in student numbers. However, it still reflects a significant pressure on the midwifery workforce and services when taken in conjunction with the Birth Rate Plus findings. We are pleased to note that the number of student midwife places commissioned by the Department of Health for 2024-25 is up from last year, with 100 places on the direct entry programme and 20 places on the course for nurses converting to midwifery. Currently, the RCM would recommend maintaining student midwife numbers at present levels for at least the next 3 to 5 years. We would anticipate that after that point, we may be in a position that for that number to be safely reduced while still ensuring a sufficient ongoing supply of newly qualified midwives. Cutting numbers too early or too deeply may reverse the progress that is being made. Retention is also key to improving the workforce situation, keeping hold of the midwives that we already have, and we need to see ongoing wide implementation of the Nursing and Midwifery Retention Initiative implementation framework, with a clear focus on retaining the experienced midwives. One of the fundamental aspects of this is the need for greater availability of flexible working. As said earlier, almost all midwives are women who at various points in their careers need to balance home, family and caring responsibilities. And when shift patterns are rigid or when minimum hours apply, some will decide, perhaps only for short periods of time when personal circumstances require it, to prioritise the needs of their families and themselves over the needs of the service. According to our SNAP poll, again that we did last month, a quarter of staff who responded told us that they had requested flexible working arrangements in the past year, but most of those requests were rejected at about 56%. The RCM recommends that there's a step change in flexible working within the health and social care services. This may need to be trialled at first, but the aim should be to provide staff, including midwives and MSWs, with more control over their hours. Counterintuitively, this may actually result in more hours being worked and more staff retained within the service. It is ultimately about keeping staff engaged within the system. If we move on to talk a little bit about the future of maternity services, the number of births within Northern Ireland is falling and has fallen to just under 13%, by just under 13% in the last 5 years. That has helped to relieve some of the pressure on maternity services. However, the level of demand being placed cannot be measured simply in the terms of the numbers of births. It is also vital that we look at the complexity of the workload that maternity services are facing. We are seeing a marked change in the demographic profile of women giving birth and an increase in the numbers of women with additional care needs. The average age of women giving birth has been steadily rising over the past decade and may well continue to do so. Older mothers are more likely to experience higher rates of medical and pregnancy-related conditions, leading to higher rates of surveillance and intervention. A higher body mass index during pregnancy is a significant risk factor for both women and their babies and can lead to conditions such as gestational diabetes. And at the outset of pregnancy in Northern Ireland, only 40% of women are within the healthy weight range. The incidence of diabetes has increased threefold between 2012-13 and 2020-21. Many other factors also contribute to an increasingly complex caseload. Mental health disorders in pregnancy are common causes of morbidity and mortality, and will to some degree be experienced by 1 in 5 women during pregnancy and up to a year after birth. The midwife has a significant public health role to contribute, whether through routine identification of these women, provision of support, and the appropriate referral of women to the community specialist perinatal mental health teams. This is important to protect the health of both the mother and the future well-being of the newborn. One key missing link is the mother's ability to access inpatient care within a dedicated mother and baby unit in Northern Ireland. Alongside this, we're seeing other significant pressures beyond the physical and mental health of women. The level of safeguarding referrals to social work services has been increasing, up by more than a third across many trusts. Midwives are working in areas with the highest levels of deprivation in Northern Ireland. The levels of vulnerability and diversity have all changed since the last review of maternity services and the last maternity strategy. Women also, quite rightly, have higher expectations. They have been promised greater choice over how and where to give birth and are involved much more in decisions than previous generations, which is as it should be. There may be some balance therefore between fewer births, but more challenging pregnancies and births that require more input from maternity services if we are to ensure, as far as possible, that they are safe. We do need to look at how the service is structured and the options available to women. At the end of the lifetime of the last maternity strategy in 2008, each trust except one offered an alongside midwife-led unit, staffed by midwives but essentially adjacent to the consultant-led unit. Additionally, at that time, there were 3 freestanding midwife-led units. As of today, no babies are being born in any of the FMUs, and the alongside midwifery-led units are struggling to stay open consistently as a result of staffing pressures. Currently, therefore, the vast majority of births are taking place in busy consultant-led units, where services are having to juggle comparatively high levels of induced labour and caesarean sections with the unpredictability of spontaneous onset of labour and birth. Requests for home births are small but rising fast. There is an increase in the number of women who choose to exercise their right to birth at home when best practice guidance recommends birth in an obstetric unit. And it is also clear that a small number of women are choosing to free birth as the only route to achieve the birth that she chooses. Continuity of midwifery care has been demonstrated to deliver safe and more personalised maternity care before and after birth, and the positive benefits of continuity of care impact across a woman's experience and perceptions of quality care. We welcome and recognise the clear evidence base for continuity of midwifery care and the plan for implementation in Northern Ireland. But the RCM believes that there are a number of key conditions that must be in place, such as the ring-fenced investment in the implementation of continuity of midwifery care and safe levels of midwifery and wider maternity team staffing. The RCM believes that the potential benefits of continuity of midwifery care for women, families and midwives make it worth the effort of putting these conditions in place to support the implementation of a safe and sustainable service. The RCM wants to see maternity services that meet the needs and choices of women and how they deliver the baby, but fundamental to it all is delivering a safe service. Maternity safety has been the focus of a series of recent reports in England following failings in services there. Most recently, Donna Ockenden review of maternity services in Shrewsbury and Telford, and Dr Bill Kirkup's report into services in East Kent, both published in 2022. We have been clear that we must not be complacent in relation to the relevance of these reports to Northern Ireland. Learning lessons from both failed and successful services is essential. Key themes exist, and we should ensure that learning identified is applied as appropriate to services here. And the concerns in these reports include things like safe staffing and workplace cultures. The Birth Trauma APPG report released in the UK Parliament on Monday highlights distressing stories of women's traumatic experiences, often exacerbated by poor communication and the lack of kindness and compassion from staff. This reflects many of the issues already mentioned, including staffing, retention, training, time to care, as well as the need for mental health services and good digital records and data. Here in Northern Ireland in May 2023, the Regulation and Quality Improvement Authority published its review of governance arrangements supporting the safety of Northern Ireland maternity services. The review revealed a need to improve the systems and processes that enable staff to do their jobs well, the need to improve monitoring and oversight of maternity services, improve arrangements for safe staffing, and improve systems and pathways for delivery of maternity care. It made 23 recommendations, to include a call for a new maternity strategy that takes into account the changes in society and important national and regional advances. We also have the findings of Birth Rate Plus, which we've already discussed, and additionally, we await the forthcoming report by Professor Mary Renfrey into maternity services in Northern Ireland, including safety issues. This will develop recommendations for policy, practice, education and research in Northern Ireland, and her work will help to inform a consistent approach to the provision of midwifery services throughout Northern Ireland, including a comprehensive and independent review of freestanding midwifery-led units. Maternity and service users and staff have been central to that process. We anticipate a robust evidence-based report with a number of recommendations for both the Department, Health and Social Care Trust, professionals and their representatives. The Renfrey report forms part of the work of the wider Departmental Maternity and Neonatal Services Safety Oversight Group, which was established in 2023. There are a number of work streams within that, but there's limited knowledge external to the department of this work or of partnership and co-production. There are likely to be a number of identified issues and recommendations sitting within this group as well. So we have a lot of work taking place, including plenty of work here in Northern Ireland, but we need to understand what happens next. What is the department's plan in order to take forward the recommendations that it has at hand? What's the timeline for that work? And what are the plans for wider engagement with stakeholders across the system? To conclude, there's an urgent need to consider how best to respond to the needs of women accessing maternity services. The increasing health and social complexity experienced by women, for example, demands different things from maternity services than has been the case in the past. Women's need for personalised care provided in midwife-led environments or through midwifery continuity of care schemes need to be factored into future plans. The assurance of safe staffing levels to provide these services must be a prerequisite, and serious consideration must be given to all the recommendations arising out of the various reviews. Fundamental to all of this is a need to recognise the transformational change required to ensure that women are at the centre of the system, not trying to navigate a system that does not meet their needs. Women and their families deserve a service that reflects the needs of the population, challenges healthy inequalities and ensures that the next generation is healthier than the one before. Thank you very much.
Thank you, Karen. Okay, I have just a couple of questions and then I'll open up to others. I mean, I suppose from a personal perspective and having had involvement in maternity services, I know just how important it is, and even when you talk around and just the huge amount of work, I mean, that our midwives do and how important they are at that time. But I suppose you talk there about the increasing expectation now of women and having more control over their birth, and I think that is so important. But in the current context of the pressures that the health service is facing, that has to be acknowledged, as you said, particularly towards the end of your briefing, by the department and how we move that forward. I know even just this week I was dealing with a constituent who a number of years ago had a very traumatic experience and suppose are still dealing with the consequences of that, and that's not to blame anyone in particular, but sometimes when people are under pressure, things can happen as well. So I think we talk about safe staffing legislation and all of that, and that's such a crucial part of it. I suppose just in relation to staffing, and I know you've said you're with the current numbers around newly qualified midwives, you're content that at the minute that's stable and those numbers don't need to change. You mentioned in the briefing paper about the NER's programme and giving midwives more flexibility in terms of their working patterns. In relation to that, and I think it's a very important point because, as you said, it is predominantly women. I know, although in my own trust story, I know one male midwife who dealt with me through my pregnancy, and he's well known, very well known. Fraser, so he's in a world full of women, so it is important to take that into consideration and how that will affect the workforce over time. Has there been any discussion with the department around the consideration of that programme? And I suppose you mentioned about the number, it was over, I think it was 56% of midwives who'd been rejected for flexible working, and the impact of that. You know, are we saying that women are feeling they have to maybe reduce their hours or even leave the profession? Is that something that we're seeing that could be evidence to say, listen, we need to really give this consideration? And I suppose my last point in relation to that is, would we then need to, if that was implemented, or, you know, in, I suppose, the spirit of it implemented through the department and the trusts, would we then need to consider increasing staff levels to meet that need?
Yeah, and I think there is a little bit of chicken and egg here, because in order to be able to facilitate flexible requests, you need to have enough staff to cover the hours that you're reducing. So it can be difficult for service managers to try and meet requests whenever they know that they haven't got the capacity. And I think it's about building resilience into a workforce system, so that you have enough people, that you've got that resilience, that you can be a bit flexible. When you talk about the NERs, basically in that service, it follows nearly a self-rostering. It requires a really good team that are very supportive of each other, and it is for short periods of time to meet specific care requirements of staff, where they basically identify what they can work, and they work that, and then everybody else builds around it, and there's a clear review process built into that, so that it's reviewed over a period of time to make sure that the situation is still the same, and that the requirement for the flexible working still exists. So I do think that we need to be innovative in terms of how we do this, and we really need to be thinking about how we support our midwives, especially if we're going to build in systems like continuity of midwifery care, which does have a requirement to do things like on call, and to work much more autonomously. I think we're going to have to start to look at much more flexible ways of working, and we're going to have to be innovative in terms of how we do that. But it is difficult whenever you are already in a system that doesn't have enough midwives there. We I think if you're talking about people leaving the system, what a number would end up doing is leaving and joining maybe the bank and working bank hours, because that offers them that flexibility. And that still keeps them in the system for us. But if we're using them through bank, then surely we can keep them on a substantive contract and give them those hours. So I think sometimes it's just we need to think that through and be a bit more, say, innovative in terms of how we use those people.
Yeah, and that actually leads into my next point around, we talk about the importance of that mix of experience and younger, newer midwives coming in to the workforce. I mean, in my own area in Southern Trust, we had a group of very experienced midwives who'd partially retired, went back onto the bank, but then there was an issue around change of contracts, and that then was a barrier to many of them, and I know it's in the process of hopefully being resolved. But I suppose just to make a comment on that, if you can, about how important it is, because it's about offering people something that works for them, because they are a benefit to the workforce. And that, like, I know certainly from my own experience of both in my own professional job and then I suppose in terms of maternity services, having someone there who's very experienced, but giving others the opportunity to learn from them, to work with them, to work alongside them, is absolutely critical. So I suppose it's for the trusts, the department, to make that as streamlined as possible, so that you're working with people instead of maybe putting barriers in place that will take them out of the system altogether.
Absolutely, and throughout my career, I can name the midwives who brought me along and drew me through and developed my experience. I think it's hugely important, and as we have that shift to a younger workforce, which is what we've needed, because we were on the precipice at one stage, it is important that those people feel supported and have opportunities to learn and develop alongside experienced staff. I think the flexible piece is absolutely, for those older midwives, what you find is that the caring responsibilities change. They change from caring for children to quite often caring for older parents, relatives. So the caring responsibilities are there, they're just different. So yes, flexibility needs to be in place for those, and with very clear review. I think it's always that bit, that there has to be clear review processes of that, where there is oversight of the flexible working processes, and that there are conversations around the situation that person is in at that time, and then reviewed on a regular basis and adjusted as required. But yeah, we're very clear. I think as well, some of those experienced midwives, you know, we have some of the trusts that have developed practice education teams and have practice education midwives to support newly qualified midwives as they come into the system. And a lot of those people who maybe are looking for more flexible working would work very well in those types of roles. You know, so again, it just comes to, I think there's something about taking a step back and actually thinking about how can we do this and how can we do it slightly differently.
Yeah, oh, absolutely. My last point then is just in relation to the points around unsafe staffing levels, and then you'd mentioned about, I think it was over 4,000 hours per week of unpaid overtime, which is colossal really when you put it into those figures. Do you think then, and I'm sure that can cause a lot of stress that potentially leads to people maybe coming out of the workforce as well, given all the reasons you've outlined in terms of the need for flexible working. Do you think then safe staffing legislation will help to address some of the issues around that? Because if people are working over and above what they should be anyhow in very pressurised situations with lower staffing levels than there should be, that's when mistakes can happen as well, you know, unintentionally, and the consequences for that can be huge. So do you feel then that legislation will help to address some of those?
I think safe staffing legislation is part of the solution.
Mm-hmm.
You know, I think it's important that it's there, and we look forward to seeing that in draft whenever it is available. It is part of the solution. We need to utilise the workforce tools that we have to assess the needs of the workforce. So things like birth rate plus, which are well validated, well used, and give us a clear indication of what we need. There is still an element of professional judgment required even around the birth rate plus figures, because there's certain things that it doesn't necessarily pick up. Things around particularly social deprivation, vulnerabilities that don't necessarily get picked up within that. So the legislation is one part of it. Then there's good validated tools that we can use to actually measure that. The other thing that Birth Rate Plus has now got is an acuity tool, which I know definitely one of the trusts is using, which helps on a daily basis to actually assess the acuity within the unit and to get escalation processes in place. So I think it's legislation. I think it's workforce assessment tools, and then it's escalation processes and working out how you escalate that and where you draw people from. The problem is whenever we have a situation where we have, you know, reduced staffing numbers, the focus will always land on the obstetric labour ward, at the detriment of things like midwifery-led units, particularly alongside midwifery-led units, community, postnatal ward. You know, they will all be drawn from to booster the staff in labour ward, where obviously the highest acuity is. And then that has a knock-on impact in those other areas. And we quite often hear stories from women, particularly in postnatal, around the availability of support and help just to care for their babies, often affected by the fact that people have been pulled to help out in other areas.
Yeah, and I suppose, I mean, you mentioned in the briefing around the increase in people having to be induced and in caesarean sections, and having come through an emergency section myself, knowing that things can change very, very rapidly, and the amount of resource and staffing that's required to deal with those situations, which can become more common as well. So it's trying to manage all of that together. So thank you for that. I move on then to Orlia.
Yep, thanks very much. Thank you, Karen, for your presentation. Just on your last point there around, you had touched on the MLUs, and I know that in the previous Health Committee we had wrote to Robin Swan around looking at an all-island network of maternity-led units, and he at the time wrote to his counterpart in the south, and both were happy to look at that approach. But again, it's sort of, as you said, you're in the scenario where you're trying to deal with emergency situations around safe staffing, etc. But hopefully that's, you know, that should be the type of things that we're working towards to try and improve services for everyone. But that's probably longer term. You know, in the meantime, I understand that it's dealing with the most acute pressures that you're under at the moment. On the birth trauma inquiry report, as you had says, it came out on Monday. So have you had much time to sort of reflect on that? And I'm just wondering, has there been any, or will there be any conversations with the department in terms of that specific report and some of those conclusions that would be relative to the North?
Yeah, if I pick up the MLU piece, you know, I think interestingly, the development of MLUs even in the south of Ireland is limited. So you know, I think looking at it as an all island approach is definitely something to think about. Mary Renfrew's report hopefully will address some of the concerns around midwifery-led units and freestanding midwifery-led units, and will give us an opportunity then to build going forward and to think about how we take that forward, and then absolutely you know, we as a college work very closely with our colleagues in the INMO, and you know, we would be very happy to sort of work with them on that. The birth trauma report I think was a very distressing report. I think interestingly, and you know, I'm happy for Stuart to pick up, many of the things discussed within the birth trauma report aren't necessarily new. They've been addressed in other reports, just in slightly different contexts and taken slightly different directions. You know, it comes back to the same set of instances: enough staff, enough time to care, the availability of training. The other interesting thing that came out in our SNAP poll was we did ask a question about people's intentions to stay or to leave. And when we asked that question, we also asked if you left and we were wanting you to come back, what would you need to come back? And one of the things was protected time for mandatory training. You know, when we've got a safety critical profession, and we reckon there's probably about 145 hours mandatory training, midwifery specific mandatory training a year. If you're not able to do that during your working hours, that puts in another additional pressure on. But it is safety critical that training takes place, and that some of that training is across professional groups that we learn together. So, you know, our obstetric colleagues, midwives, neonatologists, anaesthetics, that we actually all train together, and actually bring ambulance service into that as we start to look at more of the out of hospital births as well, and making sure that our ambulance colleagues feel suitably prepared for what they might face. So those things that come out in the birth trauma report, alongside the horrendous traumatic discourse from the women who've just been hugely distressed by it, a lot of the recommendations sit alongside what we've already got. And I think the work of RQIA, you know, I'm very hopeful in terms of the work that Mary Renfrew is going to produce, does give our department a series of recommendations and something very strong to work with. And for me, the key thing with Mary Renfrew's work is that for us in Northern Ireland, we've been proactive. We've instigated a review before we've been in a situation where we've required an inquiry. And I hope that viewpoint is continued by the department, and that they take it forward as a proactive piece of work, and that we can actually develop something that means that we have high class services moving forward. Yeah, no, absolutely. And just on the Mary Renfrew report, and you mentioned the RQIA report, and in the RQIA report, one of the key asks, recommendations, was in terms of a renewed maternity strategy, and we all know the importance of that, to try and, you know, coordinate all this work together, and, as you said, to provide the first class service. But in the briefing with the department that we had at the end of February, I had asked Peter May around how the Mary Renfrew report was progressing. So at that stage he had said that it was pretty well on, and they were expecting to see the outcome shortly. But he had says he didn't think that the maternity strategy had kicked off yet, and that the priority for the department was looking at the safety of maternity services and responding to the local and the national reports. He had then went on to say that this would provide, the Renfrew report would provide a platform for the strategy, but in terms of commitment and resource, the priority is safety of services and the development of an action plan, and that would then lead us into a refreshed and more holistic strategy. Now, and that's fine, and I understand the rationale for all of that, but what worries me is then the timeline for all this. How long is that pushing back a renewed maternity strategy? So I get that all the reports have come out in different local and national reports, but as you says, Karen, a lot of them are overlapping, a lot of them are saying very, very similar things. So I think there's a piece of work maybe the committee could assist yourselves with, and with the department, to try and look, how do we almost fast track some of this?
you know, so that you can get work can get underway to get the renewed maternity strategy for you?
Absolutely, you know, and whether it's a maternity strategy, a plan, you know, I think from a college perspective, I'd really care what you call it.
Yes.
But I do think that we definitely need a plan, and I think we have to be very careful that we don't end up with a list of actions that's just literally a tick box exercise, and we tick everything off and say yes, that's done, that's done. There still has to be a vision. There has to be a direction of travel. We need to understand where is it we want to get to. What are we identifying as the service we want to achieve? So there are certain safety critical things that need to be actioned, but then there are other things that we actually need to think about in a much more strategic way. Maternity services are relatively small. You can tell by the number of midwives in the system. There's 5 trusts. The birth rate in Northern Ireland is reflective of one trust in Liverpool, Manchester. You know, we should be able to work much more cohesively, and it probably brings us to one of the other recommendations that sits in the RQI review, and something we've talked about before, which is a form of a network where it's properly constituted. It has resource that makes sure that whenever things are produced, safety things are produced for maternity services, that they're actioned in all 5 trusts, and that there's a closed loop. So that the action goes into the trust, and there's a closed loop around the audit and evaluation of that, and we make sure that whatever it is we've decided would be a good idea to do, it's evaluated, we get the feedback from it, it gets tweaked. It's a bit like a PDSA cycle, but it needs to be done centrally. But, you know, it strikes me sometimes as strange that we have 5 trusts taking things and doing things with them. We could do that much more centrally in a much more organised way, and that would support strategy aims.
It would, and it would also, because in my own experience in terms of the trust having different guidance, I had to go between 3 different hospitals in the space of 2 weeks to have my baby, and one trust was using a different guidance in terms of preterm membrane rupture, your water's breaking early basically, but one trust had a different guidance from the next hospital I was sent to the next, and it was an absolute nightmare. And I think that if you can get that right around the coordination in terms of the 5 trust areas, that helps with the continuity of care for putting the woman at the centre. That helps with the mental health impact of going through a traumatic time. You know, I think all of these things together will really, really help, as you say, provide the best service that you can for people.
And it's around trust. If you have women who are going to different trusts where there's different policies and procedures, they get to the stage where they're not sure which is the one that's right. So it is around trust, and that trauma quite often when you look at the APG report, it is around communication. It is around what they're being told. So if you've gone to 3 different places with 3 different messages, you know, you really start to question yourself and your own abilities. So yeah, you know, I think there is something that we have a service that could, whilst it sits in 5 trusts, could be much more regional in how it approaches. Like, if I stretch back way too many years, whenever I was learning to be a midwife and training to be a midwife, we basically had the national the committee for Northern Ireland, where all the guidelines and policies and procedures for maternity in Northern Ireland were produced, and every trust used them. So it's too many years to mention, but there is a mechanism to do that, and yes, there has to be some local modification and adaptation just because of context and you know size of geography and things. But I do think it's something we can do. We do have the Maternity Collaborative, which is currently working, and that was established during the time of the last strategy, and it has done really, really good work. But it's not resourced. It is largely, you know, it's input from very enthusiastic, motivated professionals out of each of the trusts, and we could just formalise that in a much more cohesive way and make it function much better. And as I say, I think the core thing for me is closing the loop. So it's all very well producing the initiatives, but then it's how do we evaluate those initiatives and actually make sure that they're achieving what we set out to achieve.
Yeah. Okay, Colin.
Thank you, Chair. Yeah, thank you, Karen. Good to see you again. I finished the 5K and didn't collapse, so I'm delighted to be back here to ask you some questions. Yeah, look, I maybe just wanted to ask something about, we obviously have an issue within my local hospital, in the Down Hospital, where it's midwifery led, and obviously through whatever reasons that sort of is scaled back at the moment. But is that causing any pressures then by diverting sort of expecting mothers to bigger units, and then is it a straightforward journey from them like it would be if it was in a midwifery led unit, or do they end up just in a bigger hospital and amongst everything that's happening in there, and is that causing any pressures on the system there?
Yes, I think it's a good point. I worked in Downpatrick for many years. You know, the community hospitals, so Downpatrick, Lagan Valley, can bring in Causeway here as well. You know, now are much more community-based maternity services. They still provide a huge range of services around antenatal clinics. Quite often, complex antenatal clinics are provided there, where consultants will go out and see women. Postnatal care, so there is a community maternity bit there, but the births are not happening in those units. That means all of those women are being funneled through obstetric units. We do have rising rates of caesarean section, induction of labour, so that puts a pressure on those obstetric units anyway. But on top of that, then we have this other group of women who are coming in, often in spontaneous labour, so they arrive whenever they go into labour, and they will disrupt and interrupt any other work, any other planned work that's ongoing. So we know that we have some difficulties around things like deferred induction of labour, deferred caesarean sections, where women are being postponed, and some for longer periods of time than others. And that creates stress and anxiety for the women who've been deferred, because they've been told you have to come in to be induced for this reason, and now we're telling you, well, actually, no, you can wait 24 hours until we've got a space for you. But it also causes then a backlog of women for staff to pick up. So it absolutely is creating some bottlenecks. It also means that women who want to experience spontaneous physiological birth and labour are in a labour ward that is largely medically orientated, because that's what our obstetric labour wards do. So they can be more open to intervention that perhaps they hadn't anticipated. And I think what we're certainly seeing an increase in the number of women who are deciding that that's not the route they want to go. So we're seeing more women requesting home births. In one trust, we've seen an increase in home birth requests by a good 50% over the last 4 years. And whilst as midwives we generally would welcome that, what we are seeing is a significant proportion of those women requesting home births, when actually the guidance would suggest that they are safer being in an obstetric unit. And as midwives, we're not able to say, no, you can't do that. We have to support those women at home, regardless of what the risk factors are, and that's creating stress and pressure for those community teams. And the other thing that we've seen as well, and it's much harder to measure because of the nature of it, is an increase in those women who are choosing to free birth, who are choosing to birth without any medical assistance. And we certainly are aware of a slight increase in that. And that quite often is women who are trying to have the birth experience that they want, but don't feel that they can achieve that through the traditional services. So when those midwifery-led services are reduced or not available, it definitely has an impact. It has an impact on the women themselves in terms of their ability to make choices, and it has an impact on the service in terms of its ability to be able to meet the needs of those women.
And do you think, will we go back to those midwifery units, or what's the time scale for maybe conclusions of that, or is that something beyond? I think that will certainly be a focus of Mary Renfrew's work, and you know that was certainly part of the focus of that. I would expect that there will be some commentary in that report around midwifery-led services and midwifery-led care, and what we need to do to move that forward and re-establish those units. And to make sure that we have a system that, as I said in my conclusion, that's actually meeting the needs of the women themselves. Thank you, Joanna. As a former midwife in Downpatrick, thank you. I was a youth worker. I couldn't have done my work without you if you hadn't done your bit. Thank you.
Thank you. Linda?
Thank you very much, and thanks a million, Karen. A number of my questions have actually been addressed both in your remarks and then in answers to questions. But just following on from around the strategy action plan, I agree with you. I don't care what it's called. I just want to see a plan. I want to see a plan for everything. But the minister's probably sick listening to me. The officials are probably going to back saying she wants another plan. But have you been given any idea around a plan coming forward around the recommendations that are already out there? And obviously then we have the recommendations that will be coming out of the...
I think in conversations with departmental officials, obviously I meet with the CNO, the CMIDO, we know that there is a commitment there for a plan. As I say, those conversations are good conversations, and we're on the same page. But it is back to that concern about the plan needs to be more than just a list of actions. It has to have a vision, and it has to take us on a journey and a direction. We've rolled back. The last strategy ended in 2018. When we talk about midwifery-led units, freestanding midwifery-led units, we have rolled back hugely from where we were at the end of that strategy to where we are now in 2024. And I know there has been lots of reasons for that, but it's going to take us a bit of time to get that momentum going and to turn things around and to make up that lost time. So we continue to have those conversations and those discussions, and I think there is a commitment, definitely to a plan. It for me it is back to that vision. Where are we going? And we need to ensure the partnership. And it's not just the partnership, it's a partnership with the workforce and with those organisations who represent the workforce, but also with the women and families that we care for. I had an interesting request the other day by email around data. The one thing that we don't routinely do here is share the data from our maternity units around normal births, caesarean sections, inductions of labour. We have women who are having to put in freedom of information requests to find out what's happening within units. We need to think a lot more about how we actually deal with those and be much more transparent and open about the services that are there and what the outcomes of those services are.
Well, I agree with you on that. I absolutely think that's vitally important. Just as a final point, particularly given the conversation we've just had around adult safeguarding. Obviously safeguarding is a big issue, and you've alluded to it yourself that midwives are facing much more a big increase in safeguarding issues, but much more complex as well in a lot of cases. So do you feel that midwives are getting the support around that they are getting the adequate training around it, and that they have somewhere to actually refer these women, families, and whoever else needs to be referred into another service? Is there somewhere to refer them into?
Well, there are referral pathways,
but is there a person at the other end of that pathway?
There are referral pathways, and the midwives are using those. I think, as I alluded to, we are seeing a huge increase. Some of that is related to children. Absolutely, we're seeing a much more diverse population, so we're increasingly seeing instances of FGM, for example, and then you have the safeguarding issues around female babies and children, but also around trafficking and sex trafficking particularly. I've had conversations with midwives where we've identified women coming through the services who have been trafficked in, so that adult safeguarding that is there as well. Just in terms of migrants, refugees, there's a much more complex diversity out there than there would have been when I was practising actively as a clinician. In terms of support for midwives, I think when you look at other professions and the level of supervision that is built around safeguarding portfolios, I think we probably in midwifery could do an awful lot more around that supervision piece and giving midwives an opportunity, because I sometimes think that people forget that how traumatic that is for a midwife having to support in some of these situations. We're there to provide care, we're there to protect, we're there to support, and when you're in a situation, whether it's domestic abuse, whether it's FGM or whatever, it's hugely traumatic for the midwife themselves. So that need for supervision and clinical support is huge. So yeah, I think we could do an awful lot more. And often those safeguarding concerns sit very much with our community teams, and we definitely know at the minute that community teams are the ones that are more challenging to recruit into now. So that's where our deficits sit.
I appreciate that. That's something that I think we do need to look into, probably more and have more of a conversation around at some point. Thank you, Chair.
Danny?
Thank you.
Thanks, Dan.
Thank you for that very, very good presentation, and lots of questions that kind of occurred to me had already been answered. It's good to hear that the previous crisis has been averted, and it actually shows that actions can have good results and you can turn it around. So, you know, we're in a place now where we're hearing a lot about workforce crises and things, and we know we can take actions. Can I just check the typo that you mentioned?
Yes, it's in the, I think in your written briefing, and the birth rate plus, it says 90 whole-time equivalents. It should be 80.93 whole-time equivalents. Yeah. I was being a wee bit overzealous when I was writing that.
No problem. That's grand.
Yeah.
Very sorry to hear there's no births at all happening in midwife-led units. Is that correct?
No, haven't been since well over a year now.
Well over a year.
Yeah.
We have a 15-year-old who was born in a midwife-led unit at the Mater Hospital, and fantastic. My wife thought it was an amazing experience, and certainly that was the experience that she wanted.
Yeah.
They are really, really fantastic units. So
Mater unfortunately closed due to COVID at the time of COVID, because it became the red centre, and it hasn't reopened. And I think the emphasis in Belfast now is very much on the new build hospital there, so that there hasn't been any sense of that opening yet.
Certainly the value of those units is very much easily to see. Back to workforce, and workforce is something we hear again and again and again in this committee, and it's every corner of the health service. The line that 2/3 of your midwives said that their units are unsafe over the previous week, that is a striking and shocking number. Now, it does chime anecdotally with things that I've heard from midwives who have said they're working in units where they feel unsafe, they feel that they're trying to manage too much. Whenever these situations arise, I assume, like nursing, there are protocols in place for stepping up whenever there's a staff shortage, whenever there's a workload. Are these protocols being followed? And is there any way of you knowing that the protocols are being followed, that whenever somebody raises an alarm about workload and short staffing, is there a procedure that somebody is coming in and that is being checked?
There are processes, so there are escalation processes in all of the trusts. They all have procedures, and they have colour-coded processes, and you know they will move staff around to mediate particular pressures. Sometimes those pressures are short-term pressures. You know, so for example, in labour ward, if you have a couple of women who come in spontaneous labour, you know, once they've had their babies, then obviously that begins to settle. We use bank mostly. I think the challenge with using bank is that is in essence our own staff. So it is. So it has an impact on our own staff. So, you know, I recently had a conversation with a midwife who has a substantive 30-hour contract, has a bank contract to enable her to top up every so often, but actually increasingly what she's saying is she's working over 40 hours per week routinely because of the bank. And it's that pressure of wanting to look after your own colleagues. So you know your colleagues are under pressure, you know the unit's under pressure, you know what it's like because you've been there, so you do feel a certain obligation to accept those shifts in order to try and help. But that has a well-being impact. Somebody's working 30 hours because they've got reasons to work 30 hours, and in this case this individual has small children. So yeah, there are processes there. They work as far as there is available staff. So you tend to move around, and what you tend to find in it, so if you do have a midwifery-led unit that is functioning, the staff will get pulled from there. You'll see staff pulled from a postnatal ward, for example, for periods of time to try and cover, with the focus being on the labour ward, which is usually where the pressures sit. But postnatal wards now, you know, the majority of women who have straightforward births go home very quickly. So our postnatal wards tend to be very like a surgical ward. The difficulty, it's a surgical ward with a baby attached. So if you have, you know, a 20-bedded ward, half of those women have had a caesarean section, they all have a baby, you have 2 or 3 midwives, or whatever the quota is, even for that woman to be able to lift her baby out of the cot, to nurse it, feed it, change it, she needs somebody to be there to help. And that's quite often where we find our complaints coming in, and where women feel very unsupported, because quite often they press a buzzer, somebody arrives, but it could be 20, 30 minutes later, just because of the pressures in the ward. So it is difficult. The processes are there. I think if I could go back to your bit about the positive piece around the workforce, I personally believe, and Stuart and I have had this conversation, that we have an opportunity in Northern Ireland to actually be one of the first jurisdictions that end up in a situation where we don't have a midwifery workforce crisis, because we're seeing the progress being made there.
And also, we you spoke a bit, Karen, about the rise in the number, the overall size of the healthcare workforce in recent years. If the number of midwives had risen just over the last 5 years at the same pace as the HSC workforce overall, we'd actually have 180 or 190 more midwives. And Birth Plus says we only need 80. So in terms of actually there being solutions to these problems, if midwifery just in the last 5 years had risen at half the pace of the workforce overall, we wouldn't have a shortage, we wouldn't be wiped out.
It does strike me as very concerning that still 2/3 recently of midwives are saying they're working in unsafe units. You know, I think that's an alarm bell, and certainly something we should be very concerned about. Just two quick things, Chair, if you don't mind. I'll be very quick. Childcare. Childcare has been mentioned quite a lot in the Assembly since we've got up and running again. Predominantly a female-based profession. Do you know that there's many reasons why obviously women do shorten their hours or leave or go part-time or go bank? Is lack of childcare a big factor in this, and is that something that we could address in the Assembly here that may bring more midwives back?
Yeah, I think when we talk about childcare, the pressures on childcare are the same for midwives as they are for any other group of women. Availability of childcare is problematic. The other additional, and it's across any female workforce that works shift patterns. Childcare does not necessarily fit around shift patterns. So quite often, women who are working in midwifery will rely heavily on family to at least supplement their childcare. And the way that childcare is paid for, it's very difficult for nurseries and creches, for example, for a midwife to say, I want to put a child into that nursery. If the nursery is saying, well, you have to pay for 5 days a week, even though the midwife knows in her shift patterns, she might only need 3 that week. Next week she might need more. So that flexibility around childcare is difficult to factor in whenever you're looking at it. So yes, it definitely has an impact, and it will have an impact on the hours that midwives work. And back to the flexible piece, the periods of time where some flexibility. So if you're relying on your own mother, the baby's grandmother, for example, for childcare, and the grandmother is unwell for a period of time, you've lost part of your childcare, and you may need to have flexibilities built in to enable you to continue to work. Those are the sorts of things that we need to be much more innovative around, and make sure that we're supporting the workforce to stay there as a substantive workforce.
I know personally from nursing women who have had to register hours because of that lack of childcare and the availability of that childcare. So I assume that's reflected, and that's skills that we're losing. That's experienced, very experienced people that want to come and work. So it is something that we can bring back.
It's getting them back. I think once they, if they leave the workforce for a period of time, and particularly for midwifery, the confidence to come back. And how we support those people to come back into the system, so that if they're away for 6 months to a year because of childcare issues, and they want to return to the workforce, they need supported when they come back into the workforce, because things have moved on, things have changed. We've got Encompass at the minute. If somebody comes back after maternity leave with that, they need that support to get back in. So we need to be able to build that in, and again, that's back to the resilience and the sustainability of the workforce, so you have enough people there to be able to build that support.
And the more flexibility you have, the more people can juggle. I mean, juggling is suboptimal, but it's better than them having to leave the workforce entirely.
So the last thing was just caesareans. You mentioned it a couple of times. From what I understand, Northern Ireland is the highest level in the UK. And is it geographical in Northern Ireland? Is there a reason?
We certainly have in and around the highest levels of caesarean section, and it is variable across the trusts. I think the highest rate in Northern Ireland for caesarean section is about 44%. and around there. So it is quite high. That being said, what we're seeing across the whole of the United Kingdom is are rising levels of intervention and rising levels of caesarean section.
Needed or by choice?
It'll be divided into those that are elective and those that are, we term them emergencies. They're not always emergencies as in crash, but that are required during labour. The difficulty we have is that once you've had one caesarean section, the reality is that it's likely to repeat. So if you come back for a second, third pregnancy, then in most cases it will be a repeat caesarean section. So the more people have a caesarean section with their first baby, then that has an impact on their future pregnancies and increases your rate as well. So I think that feeds into some of those figures in terms of repeats. We do have a small number of women who will choose to try and have a vaginal birth following a caesarean section, and we have a few of those who request to do that at home, which does create quite a bit of stress in terms of the workforce. But I think when you start going down that line of intervention, then it perpetuates and continues.
Yeah. Okay. And finally, Alan Robinson.
Thank you, Karen. Your presentation today has been very informative. I was interested in the SNAP poll that was carried out in mid-April. I assume that was a province-wide poll. It was, including Antrim Area Hospital. Yes. It was. Okay. The reason why I asked that is obviously the loss of maternity services at Causeway, and a lot of the emphasis around that was about safe staffing levels. But if Antrim midwives and staff within there are saying that levels there are unsafe, then surely it is a case that the problem that the Permanent Secretary said, which was unsafe staff levels at Causeway, it's pushed one problem to a bigger problem. Would that be correct?
I probably wouldn't look at it necessarily that way. You've just you have gone from a situation where you had two units where there were problems in terms of staffing, and it wasn't just midwifery staffing. I think that's, certainly we're here from the perspective of midwives, but it's not just midwifery staffing. We have to bring into play here obstetric colleagues and the appropriate levels of medical staffing, availability of anaesthetics, that whole piece. I think what you do is, you either have two units that don't have enough staff, or you bring those together and try and improve the situation in one of them and make sure that one is safer than it maybe would have been beforehand. But certainly, across the board and across all 5 trusts, the feedback that we're receiving is that there are still concerns about safe staffing within them. Some of that, is just a general feeling. I think there is, from a midwifery perspective, a general feeling of fear and anxiety across the piece, just in terms of safety. I think as midwives we have felt a lot of pressure over the last number of years in terms of the number of reports of coming out, the inquiries, and midwives particularly have felt that. So some of that probably feeds into that SNAP poll as well, is that there is just a general sense of anxiety and a feeling of insecurity and fear about safety and a concern that the next person is going to be me. So I think that feeds into it as well.
You said that there had been a significant increase in home births. Is there any figures available, or could we access figures in terms of what the increase has been in the Causeway area since the loss of?
I certainly can see if I can find those and provide them for you. We're seeing it across all of the trusts that, so for example, the Southern Trust, because of the increase in the pressure for home births, actually have gone forward now to develop a home birth team. So a specific team of midwives who manage home births, and that was based on the huge increase that they had in their trust area. But I'm sure we can see what information I can get, and I'm happy to address that with you.
Okay. Thanks, Anne. Look, thank you very much. I mean, that's definitely been very helpful. I suppose just one last point, just on the back of Danny's issue around childcare. And obviously it is an executive priority at the minute. Has there been any engagement with yourselves in terms of consultation on childcare or anything like that? I think it would be important that, and likewise with maybe RCN as well, and representatives of workforce areas that have that kind of shift pattern, predominantly women, and not to take away from men, but generally that is I suppose the reality of it. I think that's very important that that's fed into the work that's ongoing, because if we do want to get this right, we have to be looking at the whole picture, and that's a big part of it, particularly in relation to when we're talking about, I mean, every week we could be standing in the chamber every single week talking about the pressures on our health and social care workforce, but we're not tackling some of the issues that will help to get people into the work and keep them there. We may as well give up.
You're very, very happy to be involved in any of that work.
Okay.
You know, I think some of the times the advantage of us as a college is the access that we have to the workforce, and to be able to gain information from the workforce. But
Yeah.
I think in terms of childcare, you know, we tend to juggle. It's just we do what women do. We just juggle things, but you are reliant and much more on informal childcare probably than you are on formal childcare, and it's just purely because of the shift patterns that you're working.
Yeah. Listen, thank you both for your
Thank you very
time.
much.
That's been very good. Okay, members, thank you. I think maybe coming out of that, I think there's definitely a question around the department's plans, the minister's plans in engaging with the childcare strategy work, and getting representation from those bodies to ensure that that's being reflected in any forward work. So members happy enough to raise that with the...
Yeah.
Worth writing a letter?
That's what I mean, yeah.
And see if we get a response.
Yeah.
Chair, I suppose that means right across the board. It's not just one subsection.
Oh, that's
of the
what I'm
work.
saying.
Yeah, it's
So
like
it's
every member of every workforce right across the
so
department.
that all those bodies, I think, because that will hopefully feed into the workforce planning for the department as well. And for the minister.
It's something I've heard from junior doctors as well, you know, right across the piece,
Yeah,
certainly in
same
nursing
here,
and certainly in midwifery.
I think everybody that works is half the problem, to be fair. I don't think it's something
There's
that's
just
unique
no
to one
choice.
But I
sector.
think-
Anybody that's
yeah.
working
But
has childcare issues, full stop, they can't afford it.
I think you're working outside of the normal 9 to 5 hours. I know certainly from my childcare perspective, I'm very heavily reliant on informal, because you couldn't expect it.
And what we'll all take turns.
Well, that does happen on occasions, unfortunately. But I think it was just a very good point, I think, as we were talking about it. So, thank you, members. We have about 45 minutes for the next section, when we have the department officials who will provide a briefing on maternity services.
Is that window behind you?
Page 27 of your pack, members.
My sister's smoking. She hasn't got somewhere beside water.
You're all very welcome. Thank you. In attendance today we have Maria McElgorm, the Chief Nursing Officer, Jim Wilkinson, who's been here a few times at this stage already, Jim, Deputy Secretary of the Healthcare Policy Group, and Caroline Keown, the Chief Midwifery Officer. So you're all very welcome, and thank you for your time today. As I said, we had about an hour, but we've sort of gone over time, so we have about 45 minutes. So if you're happy to keep we have a briefing paper, so if you're happy to keep your remarks brief, that would be good, and then we'll open up for a discussion. Okay, thank you.
Thanks. I'll just start off with the remarks. So good afternoon, everybody, and thank you for the opportunity to provide a brief to the Committee on Maternity Services in Northern Ireland. We've introduced ourselves, so I won't talk about that, but I would like to introduce Caroline in particular, who's the new Chief Midwifery Officer in Northern Ireland, and I'm delighted to have her on my team. Just want to make a few opening remarks on behalf of us all. We provided you with the briefing paper on maternity services in Northern Ireland prior to the meeting, which I hope you found helpful in providing some information. As outlined in the briefing, we recognise the critical importance of providing safe, compassionate, accessible and high quality maternity care to women and babies in Northern Ireland. This lays the foundation for health and well-being of future generations. In recent years, there have been a growing recognition of the challenges facing maternity services in Northern Ireland, including the changing demographics of service users, increasing complexity of staff, workload and concerns raised by several recent reports on safety of services for pregnant women, new mothers and newborn babies, both locally and nationally. While such reports may be difficult to consider, they provide valuable opportunities for learning and improving maternity services to ensure women and babies receive the best possible care. The RQIA's report review of governance arrangements in place to support safety within maternity services in Northern Ireland which was published in May 2023. This review made 23 recommendations for improvement within maternity services, with the learning identified applicable to all health and social care trusts and across the regional organisations. In light of such challenges, the Department established a maternity and neonatal services safety oversight group to receive assurance on the safety of maternity and neonatal services. A broad programme of work is underway with an immediate focus on addressing governance and safety issues. As you are aware, in November 2022, the Department was contacted by the Coroner for Northern Ireland with concerns and findings following the inquest into the death of a baby. The Department committed to undertake a review into the issues highlighted. An independent review was commissioned to examine midwifery services, and Professor Mary Renfrew was appointed to lead on this work. The overall aim of the work is to identify the key conditions for safe, quality midwifery services and care in all settings in Northern Ireland. As part of this, there's been extensive engagement with professionals, service users and advocates for maternity services to gather their perspective on how to shape safe, quality midwifery care services. We are currently reviewing a draft version of Professor Renfrew's report and anticipate that the final version will be submitted to the Department towards the end of May 2024 and published later in 2024, subject to ministerial consideration and agreement. I am very grateful to Professor Renfrew's commitment to lead on this important review in Northern Ireland. In addition to the independent review, the Strategic Performance and Planning Group and the Public Health Agency have completed a gap analysis across the 5 health and social care trusts. This includes implementation of relevant National Institute of Clinical Excellence, which is the NICE guidelines, Embrace UK perinatal confidential inquiry reports, and other relevant maternal reports. The work of the Oversight Group will result in an overall regional implementation plan which will be fundamental to improving maternity and neonatal services for mother babies and their families, and form the basis of a maternity and neonatal strategy. While this work is ongoing, the Department will continue to work with commissioners and trusts to ensure the safety and effectiveness of maternity services. I am encouraged by the unwavering commitment of our healthcare professionals who continue to provide exceptional care under difficult circumstances. There has been a rise in the number of student midwives across Northern Ireland, meaning that we now have a more stable workforce. The most recent health and social care workforce data indicated an overall reduction in midwifery vacancies across the region, with the midwifery vacancy rate sitting at 4.9% and the midwifery support role vacancy rate sitting at 1.9%, which is below the health and social care average. However, you have heard from Karen before us that the Birth Rate Plus tool did identify a need for an additional 80.9 midwives. As you're aware, we launched the Continuity of Midwifery Care programme in May 2023, which is being implemented by several health and social care trusts. Future workforce planning for midwifery will take the wider rollout of this model into consideration. In terms of the Nursing and Midwifery Task Group recommendations, you will note from the briefing provided that I launched the 5-year vision for nursing last year, which incorporates the recommendations for the Nursing and Midwifery Task Group and the retention report, and is based on the evidence of what the workforce requires. Our vision is to build strong foundations that will maximise the potential of nursing and midwifery family in a safe, inclusive and healthful culture, whilst recognising the value of equality and diversity within our workforce. A revised governance structure based on the 4 pillars of the vision and with a focus on population health needs has been established. The key areas will be workforce and workflow planning, which requires a collective approach. We need to prioritise the workforce sustainability, and the recruitment and retention report demonstrates how we should value our workforce and promote their well-being through focusing on leadership, safe staffing, value in staff and good working conditions. 2 key priorities within this work stream will be the refresh of the Delivering Care workforce workload planning policy for nursing and midwifery, and also to improve our data intelligence around workforce. Secondly is the education and training, which encompasses both the pre-registration and post-registration training and education for nurses and midwives. It builds upon the recent review of the post-registration education and commissioning, which was undertaken by Dr. Elaine Maxwell and reported at the end of 2022. And the third one is actually developing career pathways, which is about investing in our workforce and continued personal and professional development, supporting nurses and midwives to achieve career goals and clearly defined pathways. This will include clinical roles, operational and management roles, and education and clinical academic roles. And lastly, a quality assurance framework, which is about quality planning, quality control, and quality improvement. It also shows how we can effectively monitor and assess the contribution of nurses and midwives to improving population health outcomes across the lifespan. I have commissioned NIPEG to lead on this and to engage widely with key stakeholders. There has been significant progress in the implementation of the Nursing and Midwifery Task Group recommendations, and we remain committed to fully deliver on the remaining accepted recommendations over the next couple of years. The Department is also in the process of developing a short to medium-term Women's Health Action Plan, which identifies the priority actions across women's health services that can be taken forward within the current budget, as well as those actions for which additional investment will be required. Thank you for the opportunity today to brief you today, and we'll open to any questions that you have.
Thank you, Maria. Thanks very much for that, and thanks for the briefing as well that has been sent. I just have a couple of questions, and some of it will relate to the previous briefing we've had as well. I suppose workforce is the key issue that, as I said earlier, we're hearing across every area of the health and social care system, and I suppose unlike other areas, midwifery's a lot more stable, which is certainly very positive. But given, I suppose, some of the points we heard in the last briefing around the need for more flexible working, to allow more women into the workforce, but also so we can retain them. What consideration, you heard us talk about the NER's programme. Has there been any consideration about looking at that type of model to, populate rotas and make sure that people can work what they can, and it means then you're not having people actually just opting out altogether or reducing hours permanently, as something that could be looked at?
Yeah, and certainly there is work going on within the trusts to look at that and to be more flexible around workforce patterns. One of the things that trusts have implemented and rolled out now across Northern Ireland is an e-rostering system, which actually does allow you to effectively self-monitor, self-roster, and that has been used in different ways across the system as part of the priorities in terms of the refresh of delivering care, but also more data and workforce. We are going to be commissioning a group to actually really focus about how we can effectively utilise that system to both give us intelligence, but also to allow people to actually be more flexible around shift rostering. But Jim, do you want to pick up on
Yeah, I think the points you've highlighted are correct, and the workforce strategy in particular, the retention element of that means that you have to look at how to get the max, how to retain your workforce, how to value your workforce, and that necessarily does mean looking at traditional routes and traditional pathways and questioning what works best. And the pressure, as Maria said, is coming from multiple angles. It's coming from the workforce. How do we flexibly meet their needs? It's coming from trusts saying we need to have a workforce available, we need to maximise it. It's actually also coming from an economic push where we're saying what's the most effective way to deploy your workforce, looking at agency reduction costs, looking at better ways of filling it. So there's a whole raft of pressures to look at effectively. Implementing change, as you'll know, is never easy, but we have a commitment across trusts to look at that in terms of our workforce strategy, and we have a working group, particularly around HRDs, but also involving clinicians, to actually provide advice on how that might happen at a trust level. As Maria says, we're also investing in technology to allow that to happen better through the e-rostering project. So it's not a nut that's been cracked, but it's an issue that's clearly high in the agenda, because addressing it will help address multiple problems across funding, across use of the workforce, across valuing the workforce, and hopefully recruitment into HSC rather than individuals choosing a different route.
Yeah, no, that's good to hear, and I suppose, as you said, it's horses for courses. There's some people it suits them to have set hours, and there's others then at work and they can slot in work. So it's probably just giving people those options that will support the service that you're trying to provide. And I suppose we talked about safe staff and all of that. Hopefully it's something that would really help to improve those issues. You mentioned retention there, Jim, as well, and obviously that's a key part of it all. And I did talk about some of the issues I dealt with in my own constituency in the Southern Trust about retaining some of those more experienced midwives who were, the system was the block booking system, which worked really, really well from what I know. And then I think there was an effort to try and change that, and it wasn't well received, and it didn't work for people essentially. But I know that's something that's ongoing, and hopefully it will be resolved. But I suppose one of the things I wanted to ask is, and I know certainly lots of young women who are currently going through their midwifery training and absolutely love it. Are we seeing that generally those who train here are staying here, and that they're working then for the trusts here?
Certainly from the information we gather there, I suppose there's two angles to that. There's first, are we encouraging enough people to apply to the training course we have? And the answer there is we do seem to be getting it. That said, not complacent, because there's been issues raised around bursary levels, about bursary costs, especially for more mature students who are coming in saying we've got additional costs associated with that. Something you have to keep under review. Then the second question is, are our trainees getting employment within the HSC, and is there jobs? And sometimes we hear about blockages and we've lots of people waiting. I asked my team to look at some of this quite recently, and the figures we've got are very encouraging. And I know next week you're going to get a briefing in quite a bit of detail about workforce, but we are seeing quite a high conversion rate of most students, nurses in particular, who train here are looking for jobs within the HSC, and most of them are being accommodated within the HSC. But I think, as everyone's indicated, there's a piece of work to be done there to make sure we retain those skills, and part of that is looking at individuals changing needs over their career, which can ebb and flow in how our system does it. But contrary to some of the sort of what we hear, actually our figures would show that the vast majority of trainees take posts within the HSC in Northern Ireland, and the vast majority are accommodated in permanent posts, which is what we want. That really is the goal. If we can increase our workforce, we increase the staff, and we increase stability, and we reduce agency costs.
Yeah, no, that's good. And it sort of preempted that would be the response. I know certainly that's my experience of anybody that I know that has gone through it. Just to suppose then as well, we talked about the growing complexity of cases, and obviously all the different factors that can impact that. And in the previous briefing we talked about protected time for mandatory training. Is that something that the department is considering as well as part of this overall piece? Because as things do become more, and like we all know it, particularly in maternity services, things can change very, very quickly, and situations can arise that nobody could have foreseen. So it's about making sure that staff have the training to try and deal with that as best they can, to protect themselves but also protect patients and babies.
So the predicted absence allowance currently within the workforce in Northern Ireland is 24%, and a proportion of that will be for study leave, and factoring that in is really important across rotas. So when charge nurses and other are actually planning a rota, they should be planning for the predicted absence level. I think we all know that actually with times of annual leave and other times that will get challenged. When there's high summertime, everybody wants holidays at the same time, Christmas, so that can be hard at times. But it is a reasonably good level if people utilise that 24%. So there was a certain percentage for annual leave, a certain percentage for study leave, and that has to be planned into the rotas to allow people to do that. But that is in the work, the staffing levels, that is the predicted allowance that is expected. In reality, in terms of the expectations for continuous professional development, particularly in maternity services, I think that is often projected as being requirement as being slightly higher. So that is something that we will need to look at in terms of looking at workforce going forward. But it's sometimes hard when you've got sickness levels added in and everything else to actually balance that across the piece. And maternity leave, and Karen spoke about it, we've got a really good news story about having lots of new midwives within the system, but also they're predominantly female. They may take up maternity leave, and about how you balance that across that percentage. So that can pose a challenge in there. I think one of the things that's really important going forward with maternity services is that actually multidisciplinary training across the professionals, because we don't work as professional silos, we work as teams within maternity service, and actually having time and investment in multidisciplinary training is really, really important, and that includes with our paramedic colleagues. But Caroline is fresh from the system, so she may want to add.
I think the other thing is we are starting to get a little bit more creative about how we can actually provide that training, and there's a much more emphasis on training in the clinical areas, making good use of the practice development teams that Karen has already talked about in her previous submission, and ensuring that we're utilising times of the peak and trough in demand within maternity services to do unannounced skills training, do a simulation of an emergency and just gather the team together. So I think there's a recognition that it's not just one size fits all, that there's a range, and some of this is about embracing new technology, new techniques, and there's also been some really positive work with Queen's University and using their simulation suite, which is an absolutely fabulous facility. And certainly in the Southern Trust where I've come from, there has been absolutely great work with the skills facilitators in the maternity services, bringing the multidisciplinary team down and using that facility. So I think in the future we need to build on those simulation opportunities, spread them across Northern Ireland so everybody's getting a fair crack at using some of the technology that's available. And absolutely making sure, as Maria has already said, that we're making that balance of time out from the clinical area, but also using the time we have within the clinical areas to our best advantage.
Yeah, no, that's very good. And I suppose just my last question then, and we talked about support staff in maternity service as well, and I suppose looking at pathways then for anybody around continuing professional development and all of that, for pathways maybe that anyone that wants to upskill or move on to the next level who are probably a breadth of experience in their supporting role that would naturally want to move into, whether it's become a midwife or something else within that service. What sort of pathways are there at present, and is that something we're looking at about opening up a wee bit more? Because I think again it goes back to having that really, really important mix of experience and fresh, newly qualified people coming in.
So widening the access route for nursing and midwifery is a key priority for us in terms of actually increasing the supply. And you're absolutely right, having people with experience is really important. I think if you look at the vacancy rate among the maternity care assistants in Northern Ireland, it tells you actually that this is a really important role. And we are looking at that sort of run through to a registered midwife, and the same, there's a really good for nursing, there's a really good open university. It's pretty, I would say probably one of the strongest open university access routes. We've been doing a lot of work with the further education colleges as well around broadening that access into nursing. So I think that is really important in terms of actually, widening access and giving other people opportunities who may not want to come through a university route, but also for people who want to continue in paid employment whilst they study. I think that is really, really important. But Caroline, I don't know whether you want to speak a little bit more about the maternity care assistants, because that's a real success story, I think, in Northern Ireland.
So we've had maternity support workers for the last decade or more within Northern Ireland, and as Maria has said, a real success story in terms of broadening the maternity team. Very skilled non-registrant workforce, who are complementing the maternity team across Northern Ireland. And what we have done last year is NIPEC have completed a review of the education standards within the maternity support worker programme, and we have just launched them this year. But part of the second arm of that work now is about building a pathway for access into pre-reg. It's not going to be everybody that wants to do that, but we need to make it as easy as possible, because again, our history would show that the maternity support workers who do go on to access midwifery training stay and are very valued members of our workforce. So we're actively working at the moment to build that pathway. And we're in talks at the moment with some of the higher education institutions along with Queen's, and it's going to be a partnership work, and that's kind of twofold. It opens up the access to Queen's as well, but it also uses some of the existing passports and skills training that Queen's have developed, which we will open up then to the maternity support worker workforce.
Oh, that's really good to
While
hear.
we're saying that's at a strategic level, and you will hear about it next week. I know Phil and his team are up. We are looking across the piece in terms of pathways, because pathways are linked to retention of your skilled workforce. They're also linked to filling vacancies, because we know we carry a lot of vacancies. And as well as linking with universities and further education institutions at a departmental level, we're having engagement with the Department for Economy to see, can we make greater use, or how might we make greater use of apprenticeship pathways that exist elsewhere, and can they be applicable in Northern Ireland. Obviously, we've had a challenge for quite some time around the apprenticeship levy and how that has been funded, but those are discussions that are happening, because it does help with retention, helps with skills mix, provides career pathways, but also is an effective way of meeting your skills needs.
Okay, no, thank you for that. That's really, really positive, and I suppose it's, as you said earlier on, I think, Caroline, about being more creative about how we do things, and it's not rocket science, you know. So it is good to hear that. I could probably ask about 20 more questions, but I'll move on. I have Linda.
Thank you, Chair. Just on the back of what you just said, as somebody who's a massive fan of apprenticeships, I'm delighted to hear that. I think that this should be in every single element of everything we do, not before time. So I'm delighted to hear that. Suppose to go back to what was talked about earlier in the previous presentation, and the word I keep saying, I want to see a plan. So I would like to see and something incorporating all of the issues that we've talked about in terms of a plan. And I know not everything can be delivered. We are very, very cognizant of the circumstance that you're in terms of budget. But if we could see a plan for what we can do with what we have, and some of it is what we have to do, so I understand that, you know, you have to do it, and that's absolutely, but what we can do with what we have and what we would do if we had more. So I know this will be down to ministerial direction, so I'm not expecting you to say it to me today, but do you have any idea when we might see something like that in terms of maternity services in particular, given that that's what we're talking about right now?
It's useful maybe to talk about the construct we've used for maternity services. There's a wider debate about all health and social care and strategy and plan, and as you say, those are something that have to be looked at, and very much the debate is, what can you do with what you've got? What can you do if you have more? How do you stabilise? How do you mitigate? In maternity services, you'll see from the briefing, you'll hear the approach we've taken is there was a maternity strategy. It ran out in 2018. We started to look at a new one. You start that with a public health analysis. That was in the middle of the pandemic. We weren't able to progress that. In between then and creating a new strategy, there's quite clearly a number of reports that pointed to potential safety and quality issues in maternity services, and we prioritised that. But we prioritised that as the foundation of the plan rather than an alternative to. And how we're moving to construct the plan is to first of all do an analysis of all the reports that have happened, do a gap analysis to what extent there's an overlap between the reports in terms of what we say, because we've heard lots of that. Secondly, to do a benchmark of where are we as a system in terms of implementing those reports, and then thirdly from that, what are the actions we need to take to deliver that. That will be informed by both the gap analysis, the reports that we've commissioned, and the reports that are yet to arrive. It is undoubtedly, whilst this is a quality and safety review, it is undoubted that recommendations reports will span the whole gamut from workforce, from new practices, from better procedures, and we will create a plan that will tell us how we move forward in those. And the basis of that plan will be what can we do with the resources we've got, where do we need additional resources, and what would it mean if those resources were available. With the receipt of the Mary Renfrew report, when we have a chance to consider that and consider what it means in terms of recommendations, that with the work that has already been done in terms of baselining, NICE guidelines, baselining embrace reports, baselining the various reports that happened in England, and the RQIA report, I think we'll be in a position, certainly before the end of this year, and certainly with those reports, to have a fairly solid basis for maternity services, say this is what we need to do, this is what we do within existing resources, and this is a plan for delivery. We will have a delivery plan for 24-25 as well as beyond. Whether it's fully informed by having analysis of all those reports, that will take some time, but our intention is to have a clear 24-25 delivery plan for maternity services informed by that analysis, and also looking into the years ahead of what we can and what we can achieve.
I appreciate that, and you've probably actually given me more than I expected to get, so that's good. And my final point then just is around the issue that Alan raised around the Northern Trust, and obviously the fact that the maternity services were changed there. It was planned change, so it was managed well, I think, you know, and I think got probably fair buy-in from most people because of that. So is there work going on now between the department and the Northern Trust to look at how well that has worked? Because for me the important bit is, are people seeing the benefits of that happening? So are the mothers and babies and the staff seeing the benefit of that? Are they delivering a better service? Are we having better outcomes for the mothers and babies? And then how we replicate that, where we into other services outside of maternity as well. So to make sure that when we have planned changes to services, that it genuinely has better outcomes, that we're not doing it because we have a limited amount of staff, so we just have to squeeze everybody into this one hospital and hope for the best, and we're not actually giving them any better outcomes. So it's just getting a sense of is there actually better outcomes because we as elected reps want to be able to say confidently when we're told about planned change, we know that when planned change has been done before in a genuinely managed way with good interaction between the community, between the service users, between the staff, that it works.
Okay. Well, say the Causeway change was a planned service, so the Trust did consult on the change of service. It took views in place, and the Trust's board approved the recommendation that the services should be consolidated. In agreeing that recommendation from the board, the department approved it on the basis, and you've heard in terms of it would improve patient safety, improve pathways, but also improved it on the basis that there would be a continuous review of how the pathways are operating and the impact of it. We've had a 6-month review that's been forwarded to the department. They've been looking particularly at activity. There's a few headlines in that, and it's being analysed by our teams, but there's been no significant adverse incidents. We've seen pathways in terms of the number of births, a slight decrease, but there has been no changes in terms of the pathways to Causeway. There seems to be good feedback from both maternity services and staff. Some concern around sort of the space available, which also, as you'll know, part of that plan change was also the increase of alongside maternity midwifery unit, and I think there's a business case with the department for considering that. So it's an ongoing review, but we have had input, and we can share some of the findings from that. It's been with our SPPG department. I do think we probably have to remember that we're judging it both in quality and safety, services available, but also there was a point there where I think the Causeway were suggesting that if they weren't able to change with the demographics, they might not be able to guarantee the continuity of service. So that was part of it, part of those changes. Certainly, the service seems to be much more stable in terms of that multidisciplinary team. We've been advised that there's a significantly good feedback from the midwives and from the staff involved. We have pathways in place. I don't have the answer to the question has there been an increase in demand for home births? But again, if we have some figures on that, I'm happy to share it with the committee.
I appreciate that. Thank you, Chair.
Thank you. Colin?
Thank you. Thanks very much, and thank you for your presentation. It's probably been a breath of fresh air to actually be talking positively about a sector that's not suffering from workforce problems, and there aren't the problems in the sector that there have been in many of the other presentations that we've got. But maybe just, I think, Jim, that final point about the home births, it would be maybe really key if we could keep an eye on that, because if we are restructuring, we maybe don't want to leave a situation where people that are, in terms of proximity, further away from services, they may be opting for home births, and then maybe complications that follow that, just to make sure that we're not creating a sort of a postcode lottery in terms of proximity to services, and then the type of choices that are being made on the back of that. But you had mentioned the strategy and about reviewing it, and that there is quite a lot happening right across the whole spectrum of maternity services on that. Is it a case that you are actively working on the new strategy and updating it as these new things come in? Or are you waiting until all of these come in? Because I think if you wait until everything's done, there'll be another round of reports that come in, and that it's a constantly moving feast.
Well, I think that is part of the driver for what we've phrased as the action plan approach. So we will create, on the basis of the analysis we've done, which is primarily focused on safety, and the reviews we've commissioned, which are all coming in at a time scale. So we have the RQI reports, we have the Embrace reports, we've done our own review of gap analysis with NICE guidelines, we've reviewed our own extant SAIs. All of that information tells us the actions that we need to make to improve. We'll put that into an action plan. It'll cover across a variety of areas, and I also would anticipate that we'll start working through that. But it may well be that one of the strategic actions that will take some longer time might be to say you need to look at a new maternity strategy. So rather than saying the maternity strategy will drive the actions, we're saying let's see what we can do now, and that may well drive the need for a new strategy.
And I'd just add into that, Colin, that as part of all of that work, it's also looking at the population, the maternity and neonatal population, so to inform that process going forward. So I think the positive thing about all of this is that everything's been brought together into one place with oversight that allows you to develop a good plan of how, where you need to concentrate your efforts in terms of taking services forward. So I think that is a really big and positive piece of work that's actually happening at this moment in time.
Getting all the money that's needed to deliver that, or are there gaps?
I think that's part of the gap analysis, isn't it? What have you got, what you can deliver within your current resources, and then where is the gap that you need in terms of additionality? And I think it's really important that we do that to understand what it is that we actually need given the current financial climate that we're finding ourselves in.
There's reference in the report that you provided as well about the mother and baby, the unit at the City Hospital, and it's on a list. Is it actively on a list? Is it progressing up there, or is it really subject to capital investment that's there, or is it?
The perinatal. I think the brief makes it quite clear, and you'll have heard from colleagues actually before in terms of mental health. It's a priority, it's been identified as a need, it's on the capital list, but as with a lot of matters on the capital list, funding's an issue, and you'll have seen, I think, from the briefing as well. Whilst that's still in train to determine what our funding is available and what priority is attached to the unit, which I know has got a lot of there's a lot of priorities there, and it is one of the priorities in terms of delivery. They're looking at innovative solutions to see if there's other opportunities to try and fund such a unit, because obviously the need is great. And that's probably all we can say at the moment. That it is on our 10-year plan. That 10-year plan, as you'll know, is under constant review in terms of the available resources and the priorities, and indeed slippage within it. But can't give any commitments other than it's beyond an inkling and an eye into a firm proposal, but where it sits within the list.
Thank you, sir. Thank you. Thanks.
What do you have a question on the mother and baby unit?
Yeah, well, it was so when we had the minister in front of the committee, obviously he's made us aware of the progress around the MBU, and the business case is being progressed, and I think he mentioned the figure of around 10 million it was going to cost in capital. So I know the budget hasn't been set yet. We haven't, as a committee, seen the budget or the breakdown of where spend's going to be. But with the location and stuff identified, and with all the good work that's been done up until now, we would be very hopeful, as would the campaigning groups around the perinatal mental health.
I can't comment on, what I can comment, and you'll be well aware, the Minister will have given the figure about one particular unit. I'm sure the Minister will have also said in broad terms the gap between all the very important projects there are across the piece and what the available budget might be. So I think it's got to be viewed in the round in terms of that prioritisation process. And I think next week you're scheduled to hear some more detailed briefing on our budgets.
Budget, yeah. And see, just on the MLUs, will come up earlier on as well. So it was mentioned about the Mater Hospital, and that MLU closed down obviously due to COVID. It hasn't reopened. Well, none of them seem to be active at the minute. So could someone just touch on that briefly, if there is plans in the interim of waiting on this action plan and this strategy?
I know I'll bring Maria clear, but the actual process, as I understand it, is that the units have closed for a variety of reasons. Some related to COVID, some related to safety concerns, some related to staffing. So the different reasons for being where they are, but they're probably in the same reason for decision to open, which is wanting to learn from in particular the Renfrew report, and Maria will give some of the specific terms of reference we give to that report about those units.
Yeah, I'm happy to. So when we commissioned Mary Renfrew to take on, to lead this development of this report, on the back of the Coroner's Rule 23 letter, there were 3 strands that we agreed to. The first one, in terms of the terms of reference, was to conduct a comprehensive review of the number of staff, experience, education, training and policies required for freestanding midwife-led units. The second one was to consider the need for further guidance to all health and social care trusts in relation to the coroner's findings regarding the management of BMI and shoulder dystocia, which were two of the issues, and shoulder dystocia is an obstetric emergency. There are other obstetric emergencies, and it's really important that staff are trained appropriately around that, and to undertake further work to inform the consistent approach for the provision of midwifery services, including integration across the wider maternity services. And I know some of you will been at the initial feedback that Mary did previously, and seeing midwife-led units as external to the whole maternity system is a risk in itself. So it's really important, and I'm sure that her recommendations, and I haven't had a chance to read them yet, will be around how do we make sure that midwife-led units or home births are not seen as something over here that midwives do as part of the wider maternity context and the wider maternity service going forward. So we're really waiting for that information to come back, and I'm very confident she's done a very significant evidence base around that as well.
Congratulations, Carnine. Wish you all the best in your new role.
Danny?
Thank you, Chair. Thanks for your presentation and all your answers so far. We've got through a lot. Actually, I just wanted to dig down a bit more deeper. We've just mentioned the Renfrew report, and certainly I think it is going to be huge, and there will be some big changes and big recommendations coming in, and I'm sure we'll address that whenever the report drops. I would disagree slightly with Colin's analysis. I think there are workforce problems here, and certainly the briefing that we just got before you, the snapshot of the midwives, that's an alarm bell. 2/3 of midwives saying that the unit that they're working on has been unsafe that week. That's a very, very scary statement. 4,300 hours of unpaid overtime. So your whole system is reliant on unpaid workers doing unpaid overtime. So they're doing above and beyond their own contracts. They're adding extra stress and to a heavily stressed out workforce already. That is a workforce problem. Now, I acknowledge that there has been progress, and we've talked about that, and it's great to hear about progress in this committee here. But certainly, I just want to hear, what do you think is delivering that? Why are 2/3 of units unsafe?
So I think a couple of things there. One, across all of the jurisdictions, actually, midwives tend to work part-time. So there's a higher percentage of midwives who work part-time than other professional groups. So we look in that in the context of the use of bank. They may then do additional hours through bank. The other thing which I think is a challenge for maternity services, and having managed maternity services for many years of my career, is the unpredictable nature of childbirth. So whilst you can plan, you have an expected date to have your babies come on either side of that. So there can be days when labour wards can be very quiet. There can be days where labour wards and maternity services feel very, very busy, and indeed can feel unsafe. I think one of the challenges, and Karen mentioned and alluded to this, is there has been so much negative press around maternity services. There's the reports that have been coming out about maternity services around underinvestment, staffing levels, poor outcomes for mums and babies, is having also an impact on midwives when they come to work, and particularly at times of when it's really, really busy. And it's difficult to, because your staffing has to be in a certain number on every day, isn't it, to keep it safe. So when you've got very unpredictable levels of people coming in and out, you need to have certain flex within that system. And that will be impacted by if people are on leave, if there's sickness, if there's other things. So it's always concerning when people feel like that. I think the impact of the pandemic on maternity services was quite significant as well. And I know that work that was done by the university, Queen's University, actually highlighted how midwives, the pressure that people felt under. And I think it has taken quite a while to come out of that. So whilst we're saying there has been an investment in midwives, and there's more midwives, there's still a gap according to what Birth Rate Plus has told us. But also you have the added additionality of unpredicted workloads at times as well in maternity, which is it's different. It's probably similar to EDs. But
do you think that snapshot report of a week is unfair? Is it an unfair reflection?
I think I don't know the inside detail of that. I would want to understand that more as part of how we're doing workforce planning going forward.
Okay. I just wanted to ask you, the vacancy rate of 4.9, now that seems very low compared to 2/3 of midwives saying the units are unsafe. Does that figure include people off on long-term sick, people on maternity, retired nurses who are staying in, to fill gaps? Does that include roles that are filled by bank nurses?
So the that actually only includes vacancies that are at the point of going out to advertise. So that all of those things factor into it.
They do?
That vacancy is just jobs that are actually out for advert. So it's active recruitment.
There's another amount then that are being filled by...
so there's sickness, there will be sickness absence levels that would be in that as well. Mm-hmm. There will be people on leave. Without the vacancy factor, which is good, there will always be other pressures within the service. Understanding that is really important. Mm-hmm. And that's why I was talking to you about the e-rostering system, that we're really keen to maximise the use of that so that we can actually really understand what's driving those things. Why are we using agency? What's the background? What's the escalations? And to have much more data intelligence around that going forward. So that is a key priority for me within the system going forward, and that's for nursing and midwifery.
Okay. Are you confident that you're doing enough to drive those 2/3 of midwives who say their units are unsafe and doing 4,300 hours of unpaid overtime? Are you confident you're doing enough to bring that down?
I think in terms of the supply, so the student supply, I think that we've increased that over the last 3 years. It's remained at a higher level this year as well. So in terms of supply, yes. I think understanding those drivers, so what's actually, when people say, our staffing, what Karen is, the OSM has reported, I think we really need to understand, we need better workforce intelligence around that. I don't have the information at this moment in time that gives me that detail.
Are you doing that? Are you putting steps in place to try and get that?
So that is the re-rostering system that I'm talking about, that how do we effectively use that better across the system. That will give us that intelligence.
Do you feel 4,300 hours of unpaid overtime a week is good? Is that acceptable, or?
I don't think it's ever acceptable to have high levels of excessive use, but I don't know the detail of how much that is used against people choosing to work part-time. And Caroline is probably, they have more real-time knowledge of that, having just come from services herself.
I think the reality is that we've always had, the NHS has always worked on a bit of goodwill. I don't think we're ever going to get away from that. The reported figures, I think, are resonate across the UK at the moment. Some of it is to do with the vacancy rate, but there are other factors, as Maria has said, so the peaks and troughs of the business of maternity. But I think we can always do more. We can absolutely always do more, and some of the work that the heads of midwifery across Northern Ireland are trying to do is also provide more time for that support and reflection on practice, because sometimes the articulation of what is unsafe might not always fit the parameters of what we believe is actually clinically unsafe. So sometimes it's viewed, if there's a as part of the escalation, portion of the workforce are repositioned into certain other areas, that's leaving a gap on the ward or a gap in the clinic or a gap, and that is perceived as, oh goodness, that area is short. And yes, it is technically short, but it's on the balance of safety and of risk that there are senior midwives making these decisions every day to utilise the resource the best we can as to where is the greatest need. So that is part of the job as a senior midwife you do every day, and what's currently happening out across our 5 trusts. Sometimes that is a difficult balance. Our intrapartum areas will always take priority over some of the other areas, and that does leave some of the other areas under more pressure, particularly maybe our front door services such as our admissions area. So it does lead at times to women having to wait longer than we would want to do. We do have systems in place to try and capture that information, and as was talked about earlier, there has been a pilot done of an acuity tool related to the birth rate plus methodology in the Northern Trust, and there has been work now progressed to try and roll that out so that we're capturing in a more meaningful way those peaks and troughs and what is the actual impact. I think the exciting thing about that is that up until now we've always been nearly using tools that have been used within nursing and acute, and this birth rate plus acuity app gives us an opportunity actually to use something that's specifically designed for maternity services. So I don't take away at all from my colleagues out there, it's a pressurised job that we do, but it is about balancing that risk, and there is good escalation processes across Northern Ireland.
Just one last thing, Chair, if you don't mind. What those processes that you're talking about, when somebody does raise an alarm and says that this unit is unsafe because it's understaffed, maybe staff have been moved around, or sickness or whatever, are you confident that those processes are working and that your people are being moved in then, maybe more senior people are being called and asked to come in? Are these things happening? Are these things making sure that those wards become safer then?
They are. I mean, all of the trusts have an escalation plan. All of the trusts have a senior midwife on call outside office hours and at the weekend. So there is always a recourse to a senior midwife. Sometimes it isn't always about attending the unit. Sometimes it is about support and advice and making sure. I mean, there is a senior midwife at band 7 or above on site 24/7. So midwifery does have fairly senior people making the decisions in terms of how the workforce is utilised. So I would be confident across the 5 trusts that there is an escalation process in place, and that the senior midwives are doing the best they can with the resource that they have.
Thank you.
And finally, Alan Robinson.
Just very briefly, Jim, going back to Causeway, you'll recall back at the time last year there was, how to put this, pacifier in place where there was an indication that, or a commitment, should I say, from the department that there would be a women and children's unit at Antrim Area Hospital. subject to business cases, of course, and there was an indication of 2027, 2028. Where is that now, beyond those words at that time?
Well, I think it has been progressed by the Trust in terms of the business case. We've already talked about lots of things coming into the business case profile. I mean, it is being advanced. Their view is, and I think it is, subject to capital funding to fund it. They'll have it in, and if that is mitigated, that's one of the mitigations to some of the feedback. It says more space and more availability. So what I can say is they have advanced it. It's in our business case profile, looking at the funding, but it was quite clearly part of their plans. So we know that they put that forward as part of the plans. They've put it in the funding regime. Obviously, it'll be looking at the available funding we have and the available funding the trusts have, but that's where it is in terms of the process.
Okay, thank you very much. That was definitely very, very informative, and I suppose there's a lot of work when we hear from Mary Renfrew's report as well. I think there's lots of things that we probably will be potentially coming back to you with as well, so thank you all for your time today. Members, the next item on the agenda is item number 8, and it is the draft SL for the human medicines amendments relating to registered dental hygienists, registered dental therapists and registered pharmacy technicians, regulations 2024. If I can refer you to pages 42 to 80 of your pack. And this SL enables qualified registered dental therapists and hygienists and registered pharmacy technicians to sell, supply and administer certain medicines relevant to their professional practice. It's subject to the draft affirmative procedure in the Assembly and will not come into operation unless and until affirmed by a resolution of the Assembly, and it's due to go to plenary debate approximately the 3rd of June. So this doesn't fall within the remit of the examiner of statutory rules, and the committee did consider the proposal for this SL at its meeting on the 2nd of May and was content with the policy merit of the proposal and agreed that the department go ahead with this. So are members content? Yeah. So just to agree formally then that the Committee for Health has considered the draft SL, the human medicines amendments relating to registered dental hygienists, registered dental therapists and registered pharmacy technicians, regulations 2024, and recommends that it be approved by the Assembly. Item number 9 then is SL1, the Health and Social Care Pension Scheme Member Contribution Amendment Regulations NI 2024, page 82 of your pack. The Department is proposing to make a statutory rule to allow implementation of the new member contribution structure for 23-24 to the HSE pension scheme. The Department will uplift employee contribution bands in line with the agreed agenda for change pay award for 23-24. The statutory rule will be subject to negative resolution procedure and is expected to come into operation in May 24 with retrospective effect to the 1st of April 2023. Are members content with the merits of the policy and the Department makes the statutory rule?
Agreed.
SL1, the Health and Social Care Pension Scheme Amendment number 2, Regulations NI 2024, page 90 of your pack. Members, the Department is proposing to make a statutory rule that will introduce changes to the member contribution structure, changes to abatement provisions for special class status members who return to work, and minor amendments regarding partial retirement. The statutory rule will be subject to the negative resolution procedure and is expected to come into operation in May 24 with retrospective effect to the 1st of April 2024. Are members content with the merits of the policy and that the Department makes the statutory rule?
Agreed.
Yep. Members, item number 11 then is correspondence. Just to refer you to the correspondence list at page 109 of your pack, and correspondence is on page 110 to 276 of your pack. Just to draw your attention to a couple of items, at 11.2, correspondence from the Committee for Finance on commitments by the Minister and the Minister of Finance to bring forward the baby loss certificate scheme. Obviously this is something that we were involved in the debate. It was and it's just supposed just to make a comment that it's really good to see this is moving fairly quickly. Have members any comments in relation to that?
No, just I suppose to support that comment, it's good to see us moving quickly. It is unbelievable the amount of families who have been in contact with me through different social media outlets and my constituency office just wondering will we be able to be part of this. So I think it's probably important that we keep an eye to the retrospective nature of it.
Well, I suppose what I was going to suggest then, we write to the department to ask that they keep us updated once the next steps are confirmed. Members happy enough?
Yeah.
11.3 then is also correspondence from the Committee for Finance on scrutiny of the budget 2024-25. It's at page 112. Just members, if you're content that the clerk forwards all relevant Hansard reports and a summary of information it has requested on spending plans by the department for the budget 24-25. And I think we need to include a cover letter advising of our disappointment that we haven't received detailed spending plans, particularly given that, you know, we have been asking for this for some time now. So are you happy enough that we write on that?
What's Chair, the process for that? Are we going to get a briefing on the budget? Is that scheduled?
They're
for
due
us?
to come in next week.
Is that happening? I'd say it's to be confirmed. Is that?
Yes, sorry, Chair. Yes, we have spoken to the department, and department officials are able to come and brief us on the main estimates, and some briefing around that, but not on the detailed plans, which they don't have at the minute.
A man without a plan.
Yeah, Diane.
Budget that we're expected to pass the week after.
Yeah, that's the issue I
Let
have.
the fun begin. That's interesting.
That's you now.
All right. No, it was really just, that was my question that Colin asked, that we would at least see the estimates and make the point that we haven't seen any detailed plans.
No, it's very, very disappointing. I think we need to make that point and see as much information. And if, I mean, as soon as they're available, we will want the officials back to the committee, because we need to see that, and we've been asking for it for some time.
No, that's fine. Thank you.
Thank you. 11.4 then is correspondence from the Committee for Education, the closure of Bernardo's Time for Me Primary School Counselling Service. It's page 114. Are we content to forward this to the department for an update? Yes. Are members content then to note the actions on the remaining correspondence as listed? Thank you. I'll take you to the forward work programme and committee priorities, which is between page 278 and 280. Are members content to note the briefings as set out in the forward work programme?
Agreed.
Members, any other business?
Chair, can I just, might as well be the unpopular one as ever. At our away day, we said presentations 5 minutes. We had one today that went on for nearly 25 minutes, and it was just simply reading out what was presented to us in the report. We're all capable of reading. Is there a way that we can keep re-emphasising that, you know, just to say that don't come in and just read out what you've sent us as a report, and try and keep it to 5 minutes, because we probably would be going home about 25-30 minutes earlier today, or had more time to do something else if we can.
Well, certainly, I mean, we have re-emphasised that. I said it at the start of every briefing today, that it's brief opening remarks. I actually feel that the briefing was more than what we were provided with, so it was what we had plus additionality, which probably would have been better the other way around, even if that we had done it that way. So I mean, I'm the likes of some of the bodies coming in, we have to give them space too, and I don't want to be cutting people off in the middle of a briefing either, because I know that can be can knock people's confidence. It's difficult enough, but we are consistently raising this. But yeah, and that's all we can do. If it gets to the stage, we're going to just have to cut people off.
I suppose maybe it's just given that reassurance that we don't expect that because they come here before us that they'll read out something, because I think sometimes people feel that they have to they are absolutely justified in being here. That's why they're here. Yeah. They do not have to justify their place in being here, and we will have plenty of questions to keep them going, as the chair probably going to tell me at this stage.
Okay. So date, time and place of next meeting. The next committee meeting is Thursday 23rd of May at 2 p.m. in room 29. So thank you all.
Thank you, Chair.
Committee room 29. Sound.